This is the substance use disorder treatment community of practice, and today we are talking about emerging drug trends for substance use disorder. Yeah. Thanks for coming. Happy Friday.
Yes.
So my name is Adelaide Murray. I think I know most of you, but we do have some new faces in the room, which is exciting. I work for the new Hampshire Center for Excellence Community Health Institute, JSI. Should make up another name to add in there, just for fun and see if anyone notices. We provide training and technical assistance across the continuum of substance use disorder care, and we work with a lot of you in a lot of different contexts. Thanks for coming here. So this is my colleague Paul Kiernan, who I think everyone knows. Or the famous, I'm just the favorite. And then Melissa Sonnell in the back. And so we are here to answer any questions that you may have about your participation or continued participation or technical assistance or what the center can do for you, how we can help you, all that good stuff. So the bathrooms are down the hallway and then kind of towards the left. On the way to the bathrooms, you'll see a nice little cute coffee station should you desire more caffeine during our break or whatever. We do have a Zoom recording going for people online, so we put the phone kind of here in the middle. Apologies if it kind of becomes an obstacle, but thank you for your patience and speaking up and identifying yourself if you have a question, since there are some new faces in the room. If when you have a comment or question as we get started, you can just say your name and where you're from so we get to know each other. And then we are offering 3 LADAC and LADAC CRSW continuing credits. So please be sure to sign in, and also everyone please hand in your evaluation at the end of the meeting so that we know what we did well and what we should do better. So what we're going to do today is, obviously right now I'm doing welcome introductions, then we're going to kind of move back and forth between a little bit of like the research side of things and then practice perspectives, which we're very excited about. And then we're going to have a big discussion all together about what we do about these things. So Paul's going to start us off talking about marijuana and stimulants, which from we heard at our last meeting is kind of the main thing that people are starting to see in their practices, the meth and cocaine use as well as the normalization of marijuana. So Paul's going to give us some of the research on that, both like the basic kind of what are these things, how are people using them, and then also what are the evidence-based treatment strategies according to the literature that we should be using to treat them. Then we're going to start with Greater National Mental Health Center, talking about their experience with those substances and some research that they've actually done at their practice related to meth use, and give us some really good perspective. And then we'll have Sarah from Families in Transition, Willows, a lot of other names again like me, talking about what they're seeing in Manchester, which will lead me right into talking about spice and kratom, because Manchester is seeing significantly some issues with spice. And I just want to give you kind of the spoiler alert now that for spice and kratom, we're going to have little slides that say there's not enough research for evidence-based treatment options on either of these substances, but that's also intentional because that'll lead us into our facilitated discussion that Paul will walk us through to talk as a group about the best way to manage polysubstance use with some of these substances, treatment of some of these substances, and all of our smart brains coming up with some problem solving in absence of the real studies to back us up. And then we'll wrap up and have evaluations. So if it's your first time here today, or if it's not, I always like to remember what a community of practice is and what we're doing here. So a community of practice is a group of people who share a common interest, passion, or a concern for something they do, and who interact regularly to learn how to do it better. So that's us. We meet quarterly, and we've been going now for over a year, and I think it's going really well, so thank you all for coming. So the group was created with the goal of gaining knowledge and sharing information and experiences related to a specific topic. Obviously, our topic is specifically substance use disorder treatment, so we bring together the treatment organizations, private clinicians, other providers to gain knowledge and share information and experiences. So what's really nice about a community is that you are learning from each other. We try to give you a little bit of research or expertise from, the literature, but we really want you to share amongst each other and tell each other your lessons learned, your challenges, and problem solve as a group. I just looked down and apparently I didn't know how to adjust the font on that notes page. Anyway, So the way we do this is through our in-person meetings. We do have the opportunity for kind of ad hoc webinars or conference calls. We started to talk about that a little bit at our last meeting about wanting to put together a webinar opportunity to talk about vision, so we're working on that. We develop resources and tools when we can, so we're also working on that. I think the first tool that we're working on is about assessment. So we'll release that when we can. We also have our email-based discussion group, which is our Google group, that I mentioned at the last meeting. We were kind of switching to an opt-out situation with that. So I think that most people that were at our last meeting got added into the Google group. If you didn't get the invitation or you weren't at the last meeting and would like to be added, just let Melissa know and she'll put a little star next to your name so I know to add you. And then also always technical assistance. We're having a little bit of a discussion at the center about like what is technical assistance and what does it mean. It's such a weird term. So we're going to try to come up with a better term to make it better understandable, but pretty much what it means is we're here for whatever kind of help you need in your organization. Now that we have Paul, we feel especially steady and strong to help you should you want like practice-specific guidance or us to look through something or try to talk through something and problem solve. So I'll just skip ahead to this really quick to say that if you do just want to kind of talk something through or if there's a specific thing that you want our help with, the good place to start is requesting TA. So that just sends us an email form that gets sent. I think Rega kind of gets first flush at it, and then she will let Paul and I know if like, oh, someone from the community of practice wants TA, and now you should work on that. So other resources, everything that we talk about here today is going to be posted on your community of practice page, just here under the purple resources tab. So that'll be the slides, the recording, any kind of notes that we put together when we get to the discussion. I'll try to do some flip chart note writing so all of our good ideas can be captured. And then our Google group, like I mentioned. So let us know or email me. And if you are already a member of the Google group, you can just email this little handle there and it'll go out to everybody. We are having a little bit of trouble with maybe some organizations not being able to access the website of the Google group. So like at the end of your email, it might say like to view this discussion on the web, click here. I'm working on that. We're struggling through a little bit. I think it might be some organizations kind of blocking a Google platform. But the good news is that the emails is like, you would just see an email kind of in a different format on the same thing. You're not really missing anything by not being able to access it on the web. But I'm still trying to figure it out. Okay, like I said. So then I'll hand it over to Paul to start talking to us about cannabis and stimulants, which I think is very exciting. Hopefully you too. And then, yeah, so thanks everybody.
All right, thank you.
You're welcome.
All right, so I'm going to enjoy my favorite stimulant while we do this. But like I always say, caffeine use disorder is not in the DSM-5, so everyone's all set. With 5.1, we might be in a little bit of trouble, so we'll see. So when we kind of put everything together and sent out the survey, some of you remember the survey, you know, this was something that came up, was emerging drug trends. And Adelaide certainly understands, I certainly understand that we're probably going to learn more during the discussion from you guys because you guys are the ones doing the work and are kind of out there. So learning emerging drug trends is going to come from you. So I'm really excited for that portion of this. But I will try to make this as entertaining as I can because data can be tough in slides. I once did a very lengthy data presentation one time, and at the end during the evaluation it said death by PowerPoint. Feedback we got. So hopefully we won't go there today.
He's
but
fully traumatized by that.
yeah, I know. I've seen that story before.
Please
Yeah.
don't write that on your. You can tell me privately.
But we'll try to make it as I'll try to make it as interactive as I can. I'm also going to be reading some of the data here as we go. So when we talk about cannabis, we're going to talk about cannabis first. Different forms of cannabis. So we have kief, dabs, flowers, and hash. Okay. So the flowers are dried flowers of the cannabis plant. The buds, they call them. Kief is powder made from what do they call them? They call them the trichomes, the hairs on the outside of the cannabis buds. They scrape them off. They're very high in THC content. It makes this like powder. They can either press that powder into almost like hash. They can be sprinkled on top of other cannabis and things like that. That's the kief up there. Then we talk about hash. Hash is very similar to keef. It can be used to, with a solvent that removes the trichomes off of the buzz. You can actually use a solvent to take the resins directly out of the plant itself. A lot of times, depending on the grade of hash, they'll use leaves and stems and stuff and try to get whatever they can out of it, out of that. More high quality hash is actually the buds made out of the keef. Dabs is similar to hashish in that it's a solvent can be used to extract the plant materials, and the leftover residue is kind of concentrated and pressed to make hash. The dabs, different words for dabs, they call it hash or honey oil, which is more of a gooey substance, which I think is the one on the end. The next one is wax or butter, B-U-D-D-E-R, which is the next one. And then they have shatter, which is actually like a glassy kind of hard substance. I think that's the yellow one over behind the pointer. The yellow one right there. So those are the different forms of the dabs. The dabs, anyone know the potency of the dabs?
Close to pure THC.
Yeah, it's like 90. 90 plus. I don't think they've gotten 100 yet, but they're getting up there. So the marijuana that people smoked back then is very different than the marijuana that kids are using today. It's almost a whole different drug because of the hallucinogenic properties of it. And I was actually just chatting, with individuals who have more at risk for any kind of psychiatric disorders. This high potency cannabis can lead to psychosis and the onset of or early onset of schizophrenia and other psychiatric disorders. So, how do we use marijuana, or how do folks use marijuana? Bowls, bongs, joints. Okay, and now if you've seen for the dabs, they have it's like a glass pipe. It's almost like a methamphetamine pipe where they heat the glass and they add the dab to the heated glass and it just kind of melts in and vaporizes. But there's some of the ways that it's used. Vaping of cannabis is very popular now. It's very indiscreet. I was actually at a restaurant and it was a friend of mine's 40th birthday party, and I happened to look over and someone's using one of these dab pens in the middle of the restaurant, the bar. So they're very, very, very popular because they're so easily used. They're indiscreet. And eating, that's a very popular, much more popular way these days of using cannabis. All right, so the effects of cannabis. All right, alteration of conscious, perception, euphoria, feeling of well-being, relaxation or stress reduction, metacognition or introspection, so kind of thinking about your thinking. Adverse effects, altered body image, auditory and or visual hallucinations. Obviously, these adverse effects go up at higher doses, higher concentrations of THC. Pseudo hallucinations, tachycardia. All right, you ever have those clients like, oh, I did way too much coke, so I smoked a joint to kind of calm down? Not a good idea. Okay, you're actually making your heart rate accelerate even more. In some cases, acute psychosis and dissociative states such as depersonalization. Okay, and this is much more common nowadays with a higher potency THCs. Vaping in cannabis. Okay, we want to talk about trends. As I said before, we're seeing much more vaping with cannabis. And I'm sure most of you listen to the news, you heard about all the deaths related to vaping. So this is kind of from that study. This is mostly from an NPR study, or NPR article or report. 380 confirmed and probable cases of pneumonia-like symptoms. 7 deaths associated with vaping. Reports indicating that both users of nicotine and THC have been affected. But it's more prevalent among THC vapers. So one thing they found is that most of these 380 people are also using the pens for cannabis. Researchers are looking into whether the symptoms are a result of mixing substances. Could it be that when the substances are combined, it creates this problem? They're looking at the oils. So with the cannabis oil, as well as the vitamin E acetate, when it hits the lungs, it's an oily residue that kind of lines the lungs and creates the pneumonia-like symptoms. So vitamin E acetate has been detected in all of these samples provided. So all of these 380 have had the vitamin E acetate in there. This has become a key focus in the research. So this is really one of the things that they're looking at. They're also recommending, if you're going to vape, if you can't not vape, if you're struggling with that, make sure you're using one that doesn't have the vitamin E in it. CBD. CBD stands for cannabidiol. I sat in my car and watched YouTube how to pronounce that this morning. I was like, I gotta get that right. If I get nothing else right, I'm gonna pronounce cannabidiol correctly. What do we know about CBD? It's the second most prevalent of the active ingredients of cannabis. And while CBD is an essential component of medical marijuana, it is derived directly from the hemp plant, which is a cousin of the marijuana plant. Okay, so typically CBD is they grow strains that are very high in CBD and very low in THC, almost no THC, and vice versa, obviously. But they get with the body these days, they're able to do that. So. CBD by itself does not cause a high. There's no psychoactive properties to it. According to a report from the World Health Organization, in humans, CBD exhibits no effects indicative of any abuse or dependence potential to date. There's no evidence of public health-related problems associated with the use of pure CBD. Okay. On the other side of it, there's no CBD has been approved for the treatment of adolescent epilepsy and adult as well. I'm not sure. I think so. They have done trials. They found that it is effective in that. There's no other clinical trials. There's no evidence that it's good for anything else. Not saying it's not, but there's no evidence of that yet. Okay, because they'll tell you CBD is like the hot thing right now. If you go to the gas station, my front door had this little hanger on it. I came home and someone had been tagging the houses with this, viral CBD product. And they're saying it's like snake oil, it'll cure everything. And there's no evidence of that other than epilepsy. It has been shown to help with epilepsy. I think I've done all this. Address anxiety, insomnia, treating chronic pain, more studies need to be done. And a lot of people swear by it. You talk to people and they're like, CBD is the next best thing in the world.
I use it.
Yeah, and
Doctors are suggesting it.
Yeah, I've heard that too. Yeah.
Yeah.
There was an article about a bus driver who it was suggested by her doctor and started taking CBD. Failed her urine drug screen for the Department of Safety or whatever, and lost her job.
Right.
And she was in the news saying, hey, this actually was helpful for me, but be careful because there can be. And so for your clients, you really want to talk to them like, hey, you run the risk of coming up positive here.
Can I ask you a question
Sure.
about that? Because we actually have currently this issue in our house where a doctor prescribes CBD, but our drug screen keeps coming up positive for THC.
Yeah, and it's more expensive than sending out for the gastro analysis.
Yeah.
We'll tell you whether or not it's THC metabolites or CBD metabolites.
Right.
You can pin that down, but those send-outs are expensive.
Yeah, they are.
It's not cheap to do that. And maybe when we get to the practice discussion, there might be others in the room who have suggestions about that. That's the only one that I can come up with, but there's way smarter people here than me, so.
Well, they claim that it shouldn't come up, and so that's the other end of it.
The problem is the CBD is not, they say there's no THC, but there is.
.03 is the threshold. If it's more than .03, then it's THC.
THC, yeah.
Very similar to non-alcoholic beer.
Exactly.
Yeah, absolutely.
Yes.
So yeah, it is, because if you drink non-alcoholic beer, I don't know how many you'd have to drink to get drunk. I don't know if you do it really, but I'm sure someone could figure it out. But with the CBD, it's not like she's probably, I would guess, not using it to get high. It's just the unfortunate.
She's using it for back pain.
Yeah, the unfortunate piece is that or suggesting finding a different provider of the CBD. They may have a more CBD concentrated version of it that doesn't have the THC in it, because it's not regulated, so
Mhm.
they can't specifically say what's in it or not.
Well, is it possible that the CBD that she's using does have the higher concentration?
Could be.
Because that's
Absolutely.
happening too.
Yeah.
That they
Mhm.
label it CBD, but then they put a higher concentration of THC in
Yeah,
it.
it very, very well could be. So that might be another suggestion, is to find a more reputable supplier of the CBD.
Right.
Because if it's working for her, you know,
She claims that it's a
Yeah.
miracle.
yeah. But yeah, I would look into, and the gastro will also give you a determination, as long as it's 0.3 or higher, of how much is in her system, you know?
Right.
And whether or not this is, I'm taking CBD, I'm also smoking pot too.
Right.
Because that happens, you
Oh,
know?
yeah.
Yeah. All right, so evidence-based treatment strategies, for the treatment of cannabis use disorder. So a study published, and there's lots, in your slides, there's lots of links. I think these have been sent out to you guys, they have electronically. The links are great, there's all kinds of studies, there's all kinds of information in there, the articles we used are in there, so I would really encourage you when you have some time to look through the slides and look through all the links. There's a study published in 2016 indicating that a blend of motivational interviewing, cognitive behavioral therapy, and contingency management, motivational enhancement strategies, things like that, were effective in treating cannabis use disorder. The study did indicate that most patients, I didn't put the exact statistics up there, return to use at the 12-month mark. Okay, there's a very high percentage of them return to use at the 12-month mark. So motivational interviewing, in my experience, you know, is probably the best way to approach a cannabis use disorder. I think it's the best way to approach most disorders when someone's in kind of an ambivalent state. But we see a lot of ambivalence with cannabis use, don't we? We see a lot of people who are like, it's not a problem, it's a solution. Like that, you know, the dope was killing me, sticking a needle in my arm was the worst thing I ever did, but smoking pot never really caused any problems for me. And if we say to them, well, you know, there's all this studies that say it you know, it hampers your cognition, and they're like, well, what are you talking about? When I smoke a joint, I'd love to learn. I'd read a book. When I was a kid, I used to go to history class, and history class was way more fun when I was stoned. I found everything so interesting. And everyone's like, well, that's not true. They're like, well, who the hell are you? You know, we've beaten down any chance of having any alliance with this person. But if we say to them, okay, you know, there's a lot of things you like about it, so tell me why you're here, though. Well, you know, I got caught with it and I got in trouble, but, you know, it should be legal. Okay, and well, what else is going on? Well, you know, I failed the drug test. I was trying to get a job, you know, and I failed the drug test, and that kind of stinks. You know, I tried to stop, but I couldn't do it, you know, and then you can start having those conversations about it. But coming at it head on, like, well, I'm glad to hear you're so honest with me that it's something you enjoy, and every time you have a bag of weed, you have like 100 friends, and everyone wants to hang out with you, and you're kind of lonely otherwise, and it makes you feel smarter, and it makes you, you know, enjoy music better. But it's actually not doing those things for you, and you should stop doing it. You know, that doesn't work. So when we can come at it from an MI standpoint and have a conversation with someone and build that alliance, it can really help us to engage the person and keep them engaged, instead of having them shut down. So motivational interviewing is a really good one. So it's natural, and it's pretty much legal now. Anyway, you hear that all the time, right?
Yeah, all the time.
Yeah.
You know, well, alcohol is legal. It causes a heck of a lot more problems. Tobacco is legal. It kills more people than anything else.
Some of the time, when I explain to somebody that the way that cannabis works is almost identical to the way your body generates feel-good chemistry when something good happens,
Yep.
then I can move on to explain to them that, okay, so when you're listening to music and you're stoned, it sounds great. Well, you know, you could look at a doorknob and found it to be the most amazing doorknob for the same reason, because you're full of a chemistry that says, wow, this is cool. And most people are able to wrap their head around that, so that, you know, when they say, well, I feel, you know, I'm so much better off when I'm stoned. Yeah, you experience feeling better off because of the chemistry that, and then when you move on to say, so when you start to ingest that chemistry, your body stops producing it.
Right.
then they begin to wake up.
Yeah, yeah. So you essentially have a new reality, you know, because you're...
Well, and then sometimes I'll say, okay, so you know somebody who's been a stoner since they were in their teens, and now they're in their 50s. Has their lifestyle progressed any?
Yeah.
And they'll say, well, no, they
Yeah.
still, you know, they're a dishwasher, you know.
Yeah, yeah, and not that there's anything, and that's the other, I mean, that amotivational syndrome we see
Right.
with folks. I mean, that's exactly where this is going, is that when you have that ambivalence and the scales start to lean a little bit, and they're like, well, I'm curious, well, what are some of the problems with it? Well, I'm glad you asked that question. If you're really interested, I can share with you some information. Yeah, let me know. Well, one thing that happens is that people don't meet their full potential. Not that washing dishes is a bad employment for some people. The world needs dishwashers, okay? But if someone is capable and strives to have a lot more, then, you know, what we see is that cannabis really dampens that, you know, with cannabis use disorder, you know, I used to say that, you know, you don't see people going out robbing banks, you don't see people doing this, you know, it's not a lot of domestic violence associated with it, with the psychosis there is, you know, and things like that, but we don't go there. But, you know, we see some of those things, but what happens is people don't do much of anything. They change the ad campaigns. So you guys, you know, you see in, like, Reefer Madness, like the guy smokes a joint, like jumps out a window and like freaks out, and then, you know, they try to scare kids, and then a kid would smoke a joint and be like, I didn't freak out, I kind of liked it, that was fun, you know? They're lying to me. But the new ad campaigns were more like, you know, there's one where the kid like melts into the couch, which I kind of, you know, I think it illustrates better that amotivational syndrome is like, yeah, it may not cause some of those major problems, but what do you want out of your life, and where do you see cannabis fitting in that? Well, I want a good job. Well, you know, that might not, you know, maybe, you know, make a decision later on the road. However you have that conversation, you know, but once you can get there with a client, if you allow that adherence to their values and their principles, and make a connection with them and are working towards their common goals, it leaves the ability to add that information there at a later date. Like, hey, you know, we've been talking a little while, I kind of trust you. What do you think? I mean, you've been sitting here listening to me talk, what do you think? So if someone kind of decides, you know, I might want to stop. If you'd like to stop, we can talk about some ways to help you stop. Good old CBT, I don't think we have to go too far into that. You know, learning some thinking strategies, learning some behavioral strategies in order to avoid continued use of the substance. Contingency management, if you can stop, here are some rewards, okay? And, you know, motivational enhancement therapies and things like that have a much more kind of structured approach to this. And, you know, we can look into those too. But so these are your basic, you know, evidence-based strategies. This is all that's been shown. For this, I think SAMHSA has I think there's a link in there too for substance use disorder with motivational everyone. Or excuse me, cannabis use disorder. So these are some of those resources we talked about. Actually coming up on October 2nd, practical approaches to marijuana addiction treatment. There it is. Okay, I'm actually very curious to see that one myself. So you're all familiar with Hampshire Training Institute on Addictive Disorders being provided there. October 30th, vaping and marijuana, also at Hampshire Training Institute of Addictive Disorders. And then there's some other resources here as well. Okay. Stimulants. Okay, we're going to talk about cocaine and crystal meth. I know there are other stimulants out there, you know, a lot of medications, Ritalin, Adderall, things like that, caffeine. But we're going to focus today on powder cocaine, crystal meth. Those seem to be the most prevalent as far as the drug trends go, the ones that we're seeing the most of, that we're hearing the most of. So powder cocaine, we're talking about cocaine hydrochloride, often come with all kinds of different things. Cornstarch, flour, baby laxative is a big one. Yeah, baby laxative. Talcum powder. So all kinds of different things can be in powder cocaine. This is especially troublesome for IV cocaine users. You know, that substance with the injection site, things like that. Crack cocaine, which is a free-base version of cocaine. You take the base out of it, it's a smokable form. And crystal meth. Anything else? So, and I learned something from this. You know, I was kind of putting together the slides, and I was like, oh yeah, it's clandestine labs, you know, a lot of them around the U.S. And Allie was like, no. she said, no.
Melissa.
Okay, so yeah, so we kind of came together, and the meth is coming from Mexico mostly. The cartels are creating in much larger quantities. They've kind of driven the smaller individual labs that you see across America now, and they're able to kind of get the chemicals that they need to create it in different ways. Before it was just ephedrine or pseudoephedrine that they were using to create it in these clandestine labs, and they found ways around that. So I learned something, and we'll continue to learn something today, hopefully. So effective stimulants. What's it? Go ahead. Yes. Sorry.
It's gonna come up later, but I just was interesting that some of like the DEA people that have gone down and looked at the lab said that they kind of were ahead of us because they realized we're gonna want an alternative to fentanyl, which is what you're gonna see in a couple of slides. Actively seeking it out because like I won't die as easily or some other reasons. So they were ahead of the game. They were realizing that people were gonna want.
Yeah, they're not. I mean, they're business people. They're
I went to a meeting the other night where the Nashua Police Department was talking about meth in New Hampshire. And one of the interesting things the speaker was talking about is how the cartels have dropped the price of meth. Where it used to be very expensive, it's now very cheap, because they know that all the money and resources are being put into opioid use. So now they're sliding in meth, cheap meth from Mexico to make up that differential. So they're very good businessmen, I guess.
I don't agree with their methods, but
No.
absolutely. No, the same thing with the fentanyl. They were like, hey, poppy fields are huge. Like, we got to do all this work, and you fly a helicopter, you're going to find it. Let's create fentanyl, and let's stop making heroin, and let's create fentanyl because we can do it in this indoor building. So, yeah, and then that speaks to kind of what Addie was saying, and kind of what we're going to talk about later. Yeah, they see the trends, and they're like, hey, well, and that's why you see this uprise in methamphetamine.
Yeah, I'm not saying most, but a big number of patients on the mat now that they are perfectly stable with Suboxone or Minitrol, they come positive for cocaine and crystal meth. And the most longer conversations in my mind encounters are stop cocaine, stop crystal meth.
Yeah. And that.
Difficult.
Yeah. Difficult, you said?
It's difficult because you don't have any pharmaceutical products to really treat them.
Yeah.
And this is, has been increased for the last year.
Yeah.
More and more patients are coming positive for crystal meth and cocaine.
And that's absolutely, I'm glad it makes me, I mean, I'm glad to hear we're kind of in line, because that's what we're going to talk about that today, is that, there's a lot of the patients out there are like, well, I've got this fentanyl thing under wraps, and, I can use a little meth, it's not going to stop my breathing the first time I try it. So, now we're talking about, maybe looking at the addictive disorder that causes the craving for any substance and addressing that, and having to look at that piece, because when we get them stable with their MAT and they're stabilized for their fentanyl use disorder or their opioid use disorder, now this other thing pops up. And that's why I think we have to look at that holistic approach to look at, and not going into that, you can't, drug is drug, and, browbeating them with that, but helping them to understand that this addictive disorder affects very primitive parts of the brain, and any substance is going to create problems for you. And here are the risks associated with that. But that's very difficult. That's not easy. And there's I remember, back in like 2006, they were looking at drugs, and they were promising drugs for the treatment of cocaine use disorder, or cocaine dependence back then. And it never goes anywhere. They find these drugs. They were looking at Wellbutrin for a little while. They find all these drugs, and then they're like, oh, it's just promising, and then it never goes to approval. So I think they're continuing to try, but you're right, there's no pharmacological, anything that can be used here. So
there's another danger too, and just aside from the cartels, it's about being able to cook it in a Coke bottle.
Yeah.
And kids that are doing it.
Yep.
And adding gas, just taking arbitrary chemicals and putting them together.
Yep. The one-pot method. I told you a story about that. Yeah, I had a client once who tried to run from the cops with one in his waistband. Yeah.
I did see a DEA report too, where they, I can't remember what year's worth of data, it was recent, but they looked at all of the, drug seizures, and the number one seizure was methamphetamine.
Yeah.
So,
Yeah.
you know, that's probably the tip of the iceberg.
Yeah.
It's-
Yeah, I figured what they catch versus what's coming over.
Exactly,
Yeah,
yeah.
absolutely,
And the
yeah.
psychosis and the hallucinations with crystal meth is.
Yeah, absolutely, and that kind of segues me into, I'm talking about effects of stimulants, I'm talking about them, and we just want to kind of condense everything. Methamphetamine has much more prevalence of the psychosis that you see and things like that, but we're just kind of clumping them together. In cocaine, you see active psychosis. Back when crack cocaine first hit the streets, all the psychiatric hospitals were like, where are all these schizophrenics coming from?
Right.
You know, and come to find out, it was cocaine psychosis, because the symptoms, from what I understand, are the same. So, at any rate, you will see, you know, these effective stimulants are much greater with methamphetamine use. Methamphetamine also lasts a lot longer. When someone uses meth, it can last, you know, eight more hours. I don't know the exact numbers, I'm sure it's in here, but you know, so they're up longer. They go on these binges where they're up for 6, 7, 8 days, continuing to use methamphetamine. So effects of stimulants: increased alertness, increased energy and motor activity, increased confidence, feeling of well-being, and euphoria. Sounds all right, right? But then you look at the adverse consequences, all right? Increased body temperature, hypertension, tachycardia, loss of contact with reality, agitation, aggression, psychosis. The risk and intensity of these adverse effects are greater at higher doses, okay? And also, these risks are going to be much higher with methamphetamine than they are with cocaine. Oops. Okay, so emerging methamphetamine use. And this is where things get a little, I get reading off slides, so I apologize. But, so we talked about seizures. Someone had mentioned the seizures of meth. 142% they were up between 2017 and 2018, okay? That's huge. And that's, you know, if you see that's what they're catching, what's actually getting through. Nationally, overdose deaths involving meth and other psychostimulants rose 21% between 2017 and 2018. Some people that use drugs use it to pick themselves up after taking opioids. Okay, so it's kind of that opposite. I don't know if you guys remember that trend. You know, their landing gear, they used to call it. They would take the fentanyl or the heroin at the time to come down from IV cocaine use or IV methamphetamine use. It was because they, you know, I need my landing gear, they used to say, and then they develop a dependency on that. Now the trend seems to be swinging the other way. Is that I've been using fentanyl and I need something to pick me back up. Okay, I gotta get my dope. So, you know, the methamphetamine or the cocaine kind of helps get someone through that searching part of the addiction. They have to function. Other folks, you know, people on the streets, they use it to stay alert. It's getting cheaper. We talked about, you know, they use it to, you know, keep themselves safe. If I'm awake, no one's gonna, you know, harm me, rape me, steal from me, you know, anything like that. I can kind of stay awake and walk around the city instead of having to, you know, continually find a shelter. That won't take me anyway because I also use alcohol, whatever it may be. So, you know, there's a lot of different reasons that we're seeing with that. Also, you know, the high with methamphetamine is a lot longer, crystal meth. It lasts longer, it's less expensive, you get more bang for your buck, if you will. So from that mentality of I want to get the most out of my drug, you know, the methamphetamine's a better option, okay? And I mean, people on the street, they're not stupid. They know what's going on. They know what's going on before we know what's going on, okay? We talk to our clients, they have so many ways of navigating this world that it's like, how do we not tap into this more? That innate ability to kind of stay alive. So they're like, yeah, I'm scared, you know, I'm scared of fentanyl, or I'm recovering from my fentanyl use disorder, and I've gotten it under control, but I still have this, like, missing part of me, and methamphetamine and cocaine really make me feel better, okay? And I don't want to go back to fentanyl, because I overdosed twice, and I don't want to do that again. I've never overdosed on methamphetamine.
Well, that's what they think.
Right.
They can't die from meth, and they think they can't overdose
Right.
on meth.
Right.
That's like everybody 100% coming in telling me that. Can't
Right.
die, that's why they're using fentanyl.
Right.
Can't die.
But they can, and we all know that, but they're less likely to.
Right.
And that's true. If you're using methamphetamine or fentanyl, especially these days, are less likely to die. And that's all they hear. Because they're willing to take that risk because that addiction, that primitive part of their brain that is so strongly affected by this disorder that they're looking for something.
That's your next.
Excellent. I'm so glad you're here. I don't know what I would do without Addie. I would be lost. Okay, anyway, nationally and in New Hampshire, many people who died after a meth overdose in 2017 also had an opioid in their system, okay? 2017, 73% of cocaine deaths included opioids. In New Hampshire, more people are dying from fentanyl mixed with other drugs, okay? May not be taken seriously, chances of overdose not as great, so potentially less desire for recovery, okay? I can kind of function, you know, I can even kind of hold a job, I can kind of function on the substance, whereas the fentanyl, I couldn't function as well.
So in New Hampshire, the medical examiner's office is finding that in 2019, at about halfway through the year, we're about at where we were for all of 2018. We'll tell me about that, so definitely, the number's still kind of small, like under 100, which is sadly small in the numbers that we talked about, but definitely seeing more and more as the months progress, and a lot of us mixed together, so you'll probably have things we'll talk about in the discussion.
Thank you. Yeah, did we touch on, I know I kind of missed some of these facts. Yeah, we're talking about methamphetamine mixed with opioids as well. Those rates are going up from 22 last year. For the whole entire year, already we have 16 this year. So we're seeing a decrease in the amount of fentanyl overdoses, but an increase in the amount of mixture overdoses. So I think it's clearly on the rise. Methamphetamine is clearly on the rise. So we want, you know, when we're evaluating folks and when we're talking with folks, we need to keep that in mind.
So there's another discrepancy too, is because all of the funds, the SOAR grants are opioids, related, and they have to have a primary.
Right.
It's not a primary anymore. Meth is the primary. You can't get the funds for it.
Unless you get creative.
Yeah.
Don't fudge anything. Don't create a diagnosis that's not there, whatever you do. But yeah, that don't get me on my soapbox.
There is also the way like people who have fasting use disorder, it's the way like it's turning the trendy. 2 years ago, I was in Prague, and I had a conference on one of the persons from Hong Kong, and said that in that area, to use opioids was like something that, oh, you're not doing anything.
Yeah.
The strong thing, and if you really want to show that you have an addiction, is crystal meth. And they did not know how to stop the use. And they were saying that because the amount of use in the whole young generation, most of them are with antipsychotics, are all medicated, and it's a very difficult, it's more difficult than fentanyl because these people get to the paranoid, they don't go to, even if they stop using, they are home, they are not able to go back to the workforce. So it's something that we need to really address more than we do, because if we keep going with this trend, we will have those kids here that are not going to be able to thrive in the future.
Right. Yeah, absolutely.
Do you know if there's any studies looking at using prescribed stimulants as a way to treat meth use or cocaine use? Because it seems like often patients that we see that are using meth or cocaine, often they're like, well, when I was younger, I used to be on CBD, Ritalin.
I didn't come across any in my searches. That doesn't mean they don't exist. Yeah, I looked high and low, and throughout, like I said, like back in 2006, they were looking at drugs to treat stimulant use disorder, and I've never
So they
heard of.
figure we treat, you know, fentanyl with buprenorphine, which is another.
I have seen studies on a lot of cannabis use disorder being related to kids with ADHD, that actually they focus better when they take the cannabis. They do better in school when they're on cannabis, because it dials them in a little bit. But I've never seen anything about the treatment of stimulant use disorder with other prescription things. So yeah, Addie had mentioned before, what are your time currency?
I'm not worried about it.
All right, good. You know, talking to police officers, it's like when you go to, you know, a meth related call, it's like, or fentanyl related call, it's like, okay, like you're not as, you know, they're more subdued. Meth calls, it's like, what am I getting into right now? You know, you talk about psychosis and you know, unpredictability and things like that, so.
Hey, Paul, I just wanted to say, I know I've been in a couple of other trainings with Dr. Molly Rosino, who's an addiction medicine specialist, and she has said that there really isn't evidence around giving people high doses of stimulants to treat stimulant use disorder. It just, you know, it doesn't make the same effect. It's just almost like a completely different drug, so it's not recommended.
Yeah. And, you know, you look at that correlation versus causation and things like that. So, but anyway, more studies here. And again, I really encourage you guys to kind of click through your links. No equivalent to Narcan, that's the other thing. So it's like if someone comes in and active psychosis from methamphetamine or cocaine, you know, it's like, oh, there's no Narcan for them. You know, there's no, let's give them this drug and automatically reverse the effects of the substance. It doesn't work like that, and there's no FDA-approved medication. And again, if you're interested, you know, you can check to see.
So that is a 4-part series about specifically 2 doctors, researchers that have received a lot of federal money over the years. And every kind of part is like, they're closer, but of course still not there. So that will link you to where all of them are, so you can see all of them.
Thank you, Addie. Again, always my crush. All right, so evidence-based treatment strategies. Okay, we talk about evidence-based treatment for stimulant use disorders. Matrix model, I think probably everyone's familiar with the matrix model. I'm not a fan, if you've heard me talk about AC, I'm not a fan of like fixed length of stay, prescribed treatment, but there are some, you know, a combination of different approaches I think can be helpful looking at the matrix model. But that's the only one that has any research behind it that I could find. Is the matrix model. There's an HIV component to it. There's a high risk of HIV with methamphetamine use that they found a long time ago. But it includes elements of family therapy, group and individual counseling, building social support, 12-step recovery specifically, relapse prevention, and urine drug screens. Okay, urine drug screens are important too. You know, especially when we're testing for everything. You know, we're going to talk about spice later. You know, how many of your programs test for spice? When I was working in recovery court, all of a sudden we started testing for spice, and everybody was smoking spice. So it's helpful as a deterrent, as well as a treatment tool to be able to test for that substance, and make sure you're testing for, you know, methamphetamine and other things like that. So the matrix model, cognitive behavioral therapy, good old-fashioned cognitive behavioral therapy, and I'm going to skip down to motivational interviewing for now. You know, getting someone to where they, you know, again, using those approaches to build that alliance with the client, you know, look at common goals, you know, like, hey, you know, this methamphetamine that you're using, what's going on? Well, you know, I don't know, I don't have anything left, you know, I stopped using opiates, and, you know, it's like, it just makes me feel better, okay? So now you're engaging the person, you know, you get them talking, you use some of those MI skills to kind of get them focused on change, or if that's, you know, if that's the road that they go down. Contingency management, again, that's also part of the matrix model. That's worked in the matrix model is some, you know, rewarding, positive, pro-social, pro-recovery kind of behaviors. And good old CBT. So yeah, I just want to go back to that for a second. So these are the ones that were found to have evidence behind them. Not saying there aren't other approaches with stimulant use disorder, and that's why we're here, to learn from you guys. So you'd be like, hey, I started doing this, I have a lot of, cocaine use disorder folks. And we all have that kind of anecdotal evidence, like, I for some reason when I work with, folks who use a lot of cocaine, smells were a big trigger. And I know triggers are a big deal for a lot of people, for all substance use disorders, but, I had, cocaine use disorder was like, I was walking down the street, I smelled melting plastic coming from somewhere, and next thing you know, I was at my dealer's house, or I was at the bar, and I had 2 drinks, and next thing you know, I wanted cocaine. We hear a lot of that with cocaine use disorder. So we'll talk more about that in the discussion part. So, treatment resources, okay? So these are different, the matrix manual is up here from SAMHSA, Principles of Drug Addiction Treatment, a research-based guide, methamphetamine, some other resources is here, as well are here. Again, I would encourage you to kind of look through your slides when you have online, that way you can just kind of click on these. So that's it for me.
Any other questions for Paul?
Yeah, do you have any questions before we kind of move on? Apparently we have time.
Did you run across much of anything about when a person does present with psychotic symptoms based on stimulant use? Do those symptoms typically or not typically resolve when they stop using?
I didn't come across any research in my experience they do resolve. I'm not mental health, so I guess I'm connected with someone who can make sure that it's not a substance-related issue. But in my experience, they do resolve once the psychosis, the stimulant-induced psychosis wears off. But do other people have other experiences?
Well, we have a lot of clients at one time that all kind of present that way, so it's kind of weeding out how long those symptoms are going to last after the talk. And then weeding out, is it true, like, mental health psychosis, or is it part of, their meth use? Our doc has been using the Wellbutrin because they're reporting that it's helping with craving, with contingency management and the treatment part of it, so we do a lot of that. Because most of the people coming in are all saying I switched to meth or I'm using that in conjunction with.
Yeah, so it sounds like it's not. I mean, it's everything I hear. Like, also seeing his heads nodding and comments like that really kind of drives home that this is a real issue. This is really what's going on. I would just encourage you, if kind of like Emily was saying, make sure you're really thoroughly knowing. You don't want to say, oh, this is just this is once they come off of the meth, then the psychosis goes away. Because that one patient who it's active psychosis related to an organic psychiatric disorder, you want to make sure that you're figuring out who that is.
When my experience with doing what you're talking about right now is you need to also let the person know that the psychotic symptom may last longer than the feeling of high.
Yeah.
In other words, they may still believe that everybody's out to kill them for days after they're no longer feeling stimulated.
Right. Absolutely, it's a good point. Great point.
We're seeing a lot of pushback. The hard thing is trying to get someone treated for if it is true mental health. And being able to say, they do have a history of it, because we've had to, send a couple patients elsewhere, and the treatment providers pushing back and not understanding, and saying, no, like, they lied on intake to get the treatment, they do have a history of schizophrenia, they do have a history of this, and really weeding that out. We probably had 5 over the last, 8 months who were true, had a history of some sort of psychosis, schizophrenia, something like that. And getting them treatment is one of the hardest things, because we're getting that pushback from the mental health system.
This is a substance use issue.
Yeah.
A lot of heads down on that one too. Go over here, and then, did you have something in fact?
Oh, I was actually just going to say, I'm with Westbridge, and we see, as I was saying earlier, a lot of guys with severe and persistent mental illness, and primarily psychotic. disorders and mood disorders, and I'm just relieved to hear you presenting on the cannabis piece, because I think there's just so much public education that needs to be done. And I'm wondering if you have any thoughts on public education-wise, what we can do as organizations, because I feel like just there's so much institutional denial among the general public that pot is no big deal.
Yeah.
Even though in the clinical community for years, we've been trying to say, hey, yes, it is a big deal, this is how it's changing. I mean, it's a relief to hear you presenting on it, just because of the guys that come to us, a significant number actually have cannabis use disorder and are psychotic.
Yeah, and that's a big hill to climb.
Right.
Is, how do you get that information out? How do you change because the culture is changing into a very pro cannabis culture. How do we make sure everyone knows that it's not benign. There are
Right.
And that's a very interesting question.
I'll just say, that Melissa runs the prevention community of practice, so we'll see if we can tap into some of their resources. Paul knows that I always struggle with prevention resources that seem so, to me, removed from actual people that use drugs, right? And can be so, like Paul was saying, alarmist or whatever, and they read it, and they're like, that's not my experience, that's not what's happened to me. We watched, it actually just was released in September, this video from SAMHSA, which is, incredible. Maybe I'll link up to Google. It's like fighting the meth monster, and it's a guy in a boxing ring, and this awful, disgusting looking monster and it's and he's down, he's back up, because he's stimulated, and then it takes his heart out of his body, and can you just imagine showing that to
It's so
someone?
sensationalized.
So we'll try to find some good ones that aren't like that, and that can be used
I
more
saw that.
educational
I saw
level.
this,
Yeah.
but I think about the cannabis is maybe do a public education like we do with cigarettes. So it has to go to everywhere and not to the people who suffer for substance use disorder, because now many states, and probably here will do soon or at any moment, legal for, not only for medical. So people need to know what is the danger that goes on when they decide, okay, it's legal, so I will try. They have to know what is going to go through. Okay, if you smoke, you can have cancer. If you smoke marijuana or if you use marijuana, these are the things that can happen to you. But this has to be in a public campaign, TV, radio. So just listen. People need to be informed. So even parents can help with their kids better if they know. So it's not for the people who substance use disorder, because now this is something like recreational thing that everybody can do everywhere. So it has to be addressed like alcohol or cigarettes.
And then the problem is the way that we've gone about it, and I can get on my soapbox here too, and I won't. Right?
No, we don't have time for that.
Right. The way we've gone about this is, in my opinion, totally wrong. And that's my soapbox. But because it's legal, so if we
It's illegal.
or illegal, excuse me, if we went at it differently, because there's no federal oversight now, there's no federal campaigns to make it known, because it's popping up here and there, so yeah, I think that's added to, we're not going at this correctly.
And I don't think people understand, or parents understand, that it's a gateway. Right. They don't get that, but it's only taught. Okay, and then what comes next? It gets you into that culture and that community, and you go to one party and there's math, or there's,
Yeah.
Can I just add too, as our public education campaigns, I totally agree, changing the perception is really important. And I've worked on other ones in the past around teen canning, and, they used to be considered harmless. But I mean, in New Hampshire, even if we were to we have decriminalized pot, but if we were to legalize it and say, oh, we're gonna take this percentage of it and go to prevention, it doesn't, because, I mean, the tobacco prevention money, all from the master settlement, all goes into the education fund. Most of the money for the ads in New Hampshire and the quit line are from the CDC. The alcohol fund is the same way. It's never legally been funded as the law intended. So I think we just have to remember that too, that, you know, yes, it should be, but do we as a state stand up and do the right thing? No, because we want to have no sales or income tax. We got to fund stuff with something, you know? So it's very discouraging. One other quick thing, I was just looking on my phone because my son lives in Colorado, so I hear a lot about the benefits of living in Colorado. And, you know, the issue with CBD, as Paul said, is because it's not, hemp was made legal to grow last year in the Farm Bill, but because it's, the standards are different state by state. In Colorado, there is a licensing regulation that says, that it cannot contain more than a THC concentration of 0.3%. So if you were trying to, you know, counsel a patient around that, I don't know, it would probably take a little more time to look it up, but if there are companies that are selling in Colorado and they have to meet that labeling standard, at least it seems like, because right now it's just a Wild West, you know, and even pharmaceutical studies find like a 40 to 50% placebo effect. So, you know, anyway, so that's just something to think about as maybe an alternative, and just to try to, you know, again, it's a conversation that you have with people.
Yeah. See, that's why we do this. That's why we have community practice, because she just answered a question that you were talking about. So, other questions before we jump into the next presenters?
I have a question, but I want to kind of validate what you were talking about before with the, I just got back from Texas, which is why I was so tired, I apologize, but down there, they were talking about, they're trying to change the culture of evaluation post-detox in treatment to be with adolescents, but also with adults. So, because they found that, you know, it was like an evaluation, and, you know, you get this diagnosis, and then it just kind of sits. And nothing gets evaluated after a person has kind of gotten the substances out of their system. So they're trying to change it. They're trying to get the judges actually kind of on their side to try to promote this, because obviously it's a cost issue. But they're finding that they're getting better mental health or co-occurring diagnoses if they reevaluate after, and I don't know if that's the way that we do it here or not, but I thought that was.
That's best practice, what ASAM uses. So that is what I would encourage.
Yeah, so we just had a discussion with another entity this week about that, is that each level of care that they move through should be doing their own evaluation, and that's kind of, you know, especially the ASAM model, and it's not happening because we're putting pushback on the next level of care, like, we need to do your evaluation, because we see people through a detox and have to treat them, and they're completely different when they come in than when they leave, because of we're treating them for that detox. And putting it back on, we're talking to other treatment providers about, you need to do your own evaluation when they come to you. Yeah. And it should be done at every level of care.
Yeah, and it doesn't need to be a full, you know, biopsychosocial assessment. You can take from the previous, you know, agency. You don't have to, if the person's not having significant symptoms or issues with the trauma history, it doesn't mean you have to go back through that trauma history totally, but you can do a six-dimensional analysis and say, you know, now I'm assessing them coming to IOP from a residential treatment program and say, well, you know, how are things going? This last program we talked to, you know, how many cravings? Well, now I'm home, and like all of a sudden I have all these cravings, and I'm thinking about smoking pot. So being able to assess at every level of care, I agree, is important, you know, being able to determine, you know, what are some new problems that might be cropping up. All of a sudden I'm having more psychiatric symptoms. All these things are coming up for me. So those are great points. And that's really, we talk a lot about ASAM in here. That's really what it supports, is that continued assessment. At each, even at transition, but also, you know, when you sit around your treatment teams, you you know, you sit down and say, hey, how's Carl doing? Well, Carl's doing okay. Dimension 1, he's got no withdrawal symptoms, no nothing. Dimension 2, you go through those things. Oh, Dimension 5, he started talking about how he used pot last week, and, you know, he really doesn't want to do that because he's getting in trouble. So you can continue to assess someone's appropriateness or their level of care and how they're doing with their treatment plans. But yeah, continuing to assess it every step of the game.
Yeah.
Other comments, questions?
And we often change it. We meet weekly and do the treatment plan, and we often make a change. I have some treatment plans that have about 10 amendments in 6 months. Changing that as they complete, that's one thing, but as more come on, cravings, let's come up with alternative activities. So, yeah, so I like doing it weekly and going through the whole ASAM, so you can make changes and make it livable.
Yeah.
Yeah.
Always change, they run into new problems.
I think we will hand it over to Greater Nashua, to tell us about what's happening in their practice. So we have Angela, Kia, and Heather, and I'm surprised to see Jan. But if she jumps in at any point, we welcome that, of course.
I guess Cal, because she was on the same wavelength.
Oh. I didn't even know if I should stand up with you guys. And like,
Do whatever's comfortable.
I'm kind of here.
So, my name is Heather Smith. I am the Director of Substance Use Disorder Services at Greater National Mental Health. And first I want to thank New Hampshire Center for Excellence for inviting us to come and speak a little bit about some of the trends that we're seeing. And one of the things that one of the substances we were asked to look at was the methamphetamine. And Angela Dunham, she was an intern at the time, and she was working on a capstone actually focusing on people who use methamphetamines. And so I thought it was a perfect opportunity to share some of the points that came up in her capstone. And I'm proud to say that she's also a part of our employee now, so we invited her on. I'm going to pass it on to Angela. She's going to talk a little bit about her research, and then I'll follow up with some of our trends that we're seeing as far as use disorders. So thank you for having me. I did my capstone, like she said, on methamphetamine use. There was resilience in that, and it was a grounded theory project. These are just the participants who are from Greater Nashville, from California, the Midwest, and Canada, to get a good look at what's going on. These are some of the research questions that I'll click through. I'm not going to go into detail about them. They're just kind of general. So the purpose was the study of resilience in people who are addicted to methamphetamine. And resiliency theory suggests that there's internal and external factors that go into recovery, and that people can really come back from adversity. There we go. So the study investigated the protective factors and other areas of importance for people who are addicted to methamphetamine. So there were 7 themes that came up, and the first theme, the most important, was the effector theory. The individuals really described traumatic experiences that were violent in nature sometimes while under the influence. The theme really became an external motivator for them to change because they didn't want to go back to how they were feeling at that time. So that was the first really big takeaway, and also the traumatic experience part of that. Number 2 was self-awareness and optimism. So people felt that forgiving others that have wronged them and forgiving themselves was a huge factor in their recovery. They were able to process feelings like shame, guilt, remorse, bitterness, and also resentment that had occurred while using. They also found that finding a passion and drive for life is what keeps them engaging in the recovery community. The third was more out of life. And so the participants wanted help from recovery coaches to build a firm foundation which they can grow on. They reported that once they understood that the addiction was a disease, that they were able to kind of overcome that. The fourth theme was recovery community, so both Alcoholics Anonymous and Narcotics Anonymous played a huge factor in their recovery. Those were the top two recovery, groups that they had attended. And they said that they were able to build a strong foundation, but also with the fact that it was a safe place where they could talk about and process their emotions. 5 was having God. The participants felt that no matter how many times they failed, God was there and loved them. And also that God was, meaning that there was a plan in place for one's life, regardless of how they tried to impose their own will. 6 was family, so they really thought that, as they progressed through treatment, that the family also progressed through treatment. And even though they might not, fully understand the addiction, that they were able to be as supportive as they could. And 7 was treatment. So one participant, said that intensive outpatient was really helpful, and a lot of that goes back to the structure of the program. And also, learning how to manage life moving sober and learning how to manage time and communicate with others. So those were the themes that I got for my project. Yeah. So these are just the questions. They're really open-ended. Try not to have any bias. And the themes. You may have any questions that you would like to ask Ms. Love.
Was the information in the survey form, or was it,
They were open-ended interviews, kind of
interviews?
asking, trying to keep really open-ended, non-biased questions to see what their experiences were, and then taking that and kind of analyzing the data.
And were there many interviews, or?
There were 5 interviews.
5, spaced out? Sorry,
About
that's
2 to
one
3 months.
Okay,
I
thank
didn't have a
you.
whole lot of time.
Okay, got it.
I would have liked to have 11, but.
Yes,
we're
yeah.
good.
Nice,
Yeah,
thank you.
Any other questions?
How was the family involvement, or family number 6, how did that impact, or what was kind of the outcome of the questions?
So some of the individuals said, well, my husband or my, one of my family members, gives me a ride to AA, but, they might not fully understand what was going on with them, so they were kind of learning through the process, but also being, supportive in the way that they could be, like giving a ride.
Gotcha.
Sorry if you already said this, but so were these people in recovery already?
Yeah.
So it's like retrospectively looking at, they were, okay.
It was, yeah, the 5 that I had were all in recovery. I think that it would be difficult to find people who were actively using.
Yeah.
They don't really want to talk about it.
So do you think when you ask them, like, how can the community as a whole, probably more than likely they're just responding to their own experience of how the community around them, or maybe what they didn't get in the community and they needed? Do you remember from the interviews at all?
Yes, they were saying that, NA and AA were the recovery communities that they really found where they could open up and share because it was a safe place. Other people really knew what was going on. They've gone through similar experiences.
Did you say the themes were kind of, are they rank ordered?
They are ranked,
Okay.
yeah, so one had the most, hits in the analysis, number 2, number 3, and then some of these were a similar number of.
What kind of, treatment or follow-up were these people doing after they were in recovery? Because all these people go to recovery and you got this information.
Yeah.
At this point, what was the major of this treatment? What they were doing at that point?
What were they doing? So the majority of them were attending recovery meetings at that point, but they were able to look back and say, well, IOP was really helpful for me because of the structure and the way that I could process, shame, guilt, feelings like that.
And at this point, what they do, recovery prevention, they do groups, or they don't do anything and they feel that they are safe without doing anything.
No, all 5 of the individuals that I talked to were engaged in some kind of recovery community, whether it be, like NA or AA, that was the majority of it, was with NA, and then some people had gone to alcohol afterwards, so they were also engaged in AA, and they found that those skills that they had learned were helpful for them. Yep.
I just actually, had a few minutes, so recovery community, I run a 12-step house, so I just noticed that when people do a lot of research, they put recovery community versus AA, NA.
Yeah.
Is there a reason why that is?
I wanted to keep it kind of vague because there was a lot underneath that, like,
Yeah.
there was, smart recovery, they would just sometimes say group, or, sometimes they would say NA or AA specifically, but there's a lot underneath recovery community that comes into play for sure.
Mhm. That's why I was curious if it was actually AA, NA, or if it was like
There was
other.
a lot of other stuff,
Yeah.
like smart recovery and other groups that they were attending,
Mhm.
anywhere that they could find support.
Mhm.
Was there any information about, relapsing? Like, how many times maybe, because that's a huge deal with, the women that I treat with meth, is the recovery, it seems like the relapsing rate is higher.
Yeah, I do see that too with my own clients, that can happen, and, it's just understanding that you can come back from that a slip doesn't have to be your relapse. And I think that we all need to encourage people to keep going forward. A lot of them didn't want to go back to where they were, because of the negative side effects, but sometimes people in their life might, say, oh, here, why don't you have some of this? And sometimes it's just that impulsivity.
Just gonna kind of throw this out here, where Jan and I just come back from Texas and attending, doing a tour of a recovery program and being in a recovery community. It was interesting being in Texas in the South, Bible Belt. Their first thing we were taking pictures of the recovery program. But one of their things is that they are a spiritual-oriented program that recognizes God as a central authority. So it was just interesting, like, it's just kind of the four people that you evaluate in your project, maybe God would have been first versus, going down that aisle in terms of their treatment and stuff. So I just found that was, interesting from here up north.
Yeah, that's true. The population really plays a big part in what your research is going to look like.
In a similar vein, I just thought it was really interesting that God was ranked above family.
Yeah.
And especially in relation to the comment that, no matter times how they felt like God was always there and loved them. Because, that's what we want from any attachment fit here, right? That's what we're kind of supposed to have in ideal circumstances, and we don't always get that from our families, particularly.
Or if you burned a lot of bridges with your family too.
Yeah, sure, yeah, very true.
Yes, and how were the participants chosen? Do they have to be in recovery for a certain period of time? Had they been in a certain treatment facility? It is kind of scary to me that that's number 7, so.
So the participants were pretty much chosen at random. They just had to have some kind of methamphetamine use. They didn't have to be in recovery for a certain amount of time. I just think that, it's difficult to get people who are active in recovery. I tried.
Yeah, so did you have like a notice saying, if you're interested in this study, give me a call, or?
It was more word of mouth, kind of
Okay.
going around saying, I'm doing this project, if you have anybody who's interested, just let me know.
Nice.
And also some of my clients,
Thank you.
So I think, really, one of the reasons I asked for Angela to share is also to show, there is hope, and looking at the themes that she pulled from, even though it was a small percentage, but she got some information that we can look at and start to think about, okay, so these are important themes that came up that help these individuals to not go back. And so, I think that we can use this in our own perspectives and how we treat our clients. So I wanted to share a little bit about Greater Nashua and the trends over the last few years on some of the substance use disorders that we're talking about today. So I have down cannabis, I have down amphetamine, cocaine, and I wanted to put down opioids just to show a little bit of comparison. And this, there's a lot of disclaimers that goes with this. This is not exact. This is just a rough pull from the science that are active in our system right now at Greater Nashua. So everyone that's active, there's about 2,400 clients within Greater Nashua mental health, and out of those, about 70% have a substance use disorder. So out of all the different substance use disorders. And so I wanted to pull down, again, these four, and if you look, you can see that out of the data I was able to receive, there is a trend in the amphetamine going up. And I thought that was pretty interesting. I know that we talk about, in generalities, that we see methamphetamine use going up, but to actually get some rough data from our agency and put it into a chart, it is. It actually is. We do see that more people are being diagnosed with some sort of amphetamine use disorder. So that's another disclaimer there. I don't know how many of this number is methamphetamine versus amphetamine, but it is clearly going up there. If you notice that in 2019, the numbers are a little bit down here in the graph, and that's just because we're not through with the year. And so the next number is just showing if the trends for this year, what it should be at the end of the year. Down at the bottom. So down at the bottom, we have the different substance use. That was F code.
Just as a code.
Yeah, the F code. So for those who need a review, F15 is your amphetamine code, F14 is your cocaine, F12 is your cannabis, and F11 is your opioid. So this was really interesting to see the different trends. Any questions? I also wanted to note, too, that there were about 950 out of those who have a substance use disorder in our system that do have more than one SUD associated with their use.
Oh, I just thought it was interesting that everything seemed to be trending up.
Yes, actually. So we're growing as an agency. So by bringing on individuals like Angela from internships, and so we are growing as an agency. So again, that does kind of play into the data that we pulled in. Also, for those who don't know, we have drug court for Hillsborough South that's part of our agency, and so over the years that has gone up. We started that about 3 years ago, so the more that we're pulling from the drug court also goes into this. And a lot of the F15 codes are coming from the drug court.
It's interesting that's the only one that isn't really dipping.
Exactly, yeah. And I thought that was, I had no idea what I was getting myself into when I got the data. I just was going at it, and I was given a list of everyone that has any SUD in our system, and I went through and pulled, and when I charted it out, I said, wow, look at that, it's right there.
Similar to what we shared about the medical examiner office finding that like halfway through 2019, they're seeing similar to full numbers of pain.
Absolutely. Thank you.
Thank you very much.
That's what we have for slides. I just wanted to wrap up. I know we talked a little bit about two of our other employees in the audience today, Gian and Kia, and they talked about being in Texas, and that's really part of our substance use department as well. We are working with the Creating Connections New Hampshire project, and that is serving adolescents from 12 all the way up to 25. And so I'm hoping by working through this project that we also will bring in individuals to help treat them. Thank you. Now we will have Sarah tell us a little bit about financial care. Something that that was interesting, in just talking with Sarah and then talking with Nashua, and the differences was, we talked with Sarah first, and she had shared, some things that she was seeing, and then when we asked in Nashua, they were like, oh, not so much. So it'll be interesting to hear some of the differences that Sarah was
Thank you. So my name is Sarah Bernier. I am from Families in Transition New Horizons. I am the program manager for the Willow Substance Use Treatment Center. So again, lots of names for everybody this morning. And so my role is I really oversee the intensive outpatient programming and the outpatient programming for men and women. And so I imagine you've heard there's a lot of news in Manchester around substance use disorders. So I'll talk a little bit about that today. Got it.
Like, I've never seen that before.
So I just want to talk a little bit about some of our substance use programming that we have right now. Families in Transition New Horizons is really known for housing services, but over the years, we've developed a lot of clinical and supportive services because we've seen such an increase with substance use and mental health in the homeless population. So just to highlight some of our programs, again, doing a shout out for my intensive outpatient and outpatient services for men and women. And then we also have transitional living services for both men and women. So these are single beds. We have 14 for men and 25 for women to support them in recovery. Right now, we do have a certified recovery support worker who is at the New Horizons shelter. She is very, very busy. But her role is to help connect folks who are coming into our shelter, who are staying in our shelter, into some kind of treatment modality. Typically it is residential, but once in a while we do get IOP, outpatient services based where someone is at. We have a new project through SAMHSA for our outreach team in Manchester and the Concord location. So we have 4 outreach workers who are going into the tent communities, who are going under bridges, who are going out to meet people where they are at, to talk a little bit about services that are available to them. We do have recovery housing for both women and children. We have 11 units on Wilson Street in Manchester, and that focus is to help reunify children with their mothers who are in DCUS custody. So we have 11 units available there with a very long wait list, as you can imagine. And then we have an open doors program, which is about it's like a child and family program. It's for bonding and attachment. Again, going back to those DCUS referrals, how do we help a family unit kind of work together while a parent is recovering from substance use? I did it again. What am I doing here? Here we go. Yes. So emerging trends to what we have typically seen. So I thought I would actually start with a positive one that we've seen, and so we have actually seen a huge increase in medication-assisted treatment services, either people coming in already established or people who are actually interested in exploring that a little bit further. So I think that's a huge shout-out to our community. I know there was a huge effort to do a lot of recruiting of primary care providers to be able to prescribe this medication. So we have seen such an increase, which is really exciting to hear. There's not as much stigma around it as what we're hearing. I mean, these are probably pretty familiar with what folks are seeing other places as well, but right, we're not really seeing heroin use anymore. It's mostly fentanyl use. I spoke with my intake worker about this presentation, and I said, tell me a little bit about what you're seeing at intake, and she had noticed that people are reporting heroin use on the phone, but then when they come in to sit at their actual face-to-face assessment, they're actually disclosing the fentanyl use. So I just thought that was really interesting, that over the phone I'm willing to tell you that I am struggling with heroin, but actually when I'm coming in, we're talking a little bit more about fentanyl. And then the increase of use of methamphetamines, cocaine, and spice. I almost wish I put spice first here, because obviously that's a huge concern that we're seeing in Manchester right now. But as I'm kind of echoing everything that's been shared today already, but we are seeing the increase in methamphetamines and the cocaine. And I think, again, going back to what Paul was saying earlier, hey, I'm on MAT now, so I'm doing okay with my fentanyl use, but now here we are having the methamphetamines piece in. And then just again, to speak to the ongoing THC use, a lot of the times we're very much in the pre-contemplative stage of change. Around THC use, it's not a problem for me, there's no negative consequences for myself, but then sometimes, right, we have that opportunity to use that motivational interviewing when someone is popping positive for, methamphetamine or cocaine. Well, it was actually
great conversation to be able to have with folks, and to kind of get in that front door about talking about how it is a concern. So I thought I'd separate it out a little bit, because we have so many substance use programs, that sometimes, like our CRSW, our outreach teams, we're really working with folks in the pre-contemplative and the contemplative stage of change. So things are a little bit different on how we approach clients. Obviously, motivational interviewing, which again, we've talked pretty deeply about today, going and meeting people where they're at and having conversations about what's going on in their lives. We're blessed to be able to have our team being able to go to participants. Having a client come in for an appointment, you need to be here at 1 isn't always feasible. And so we have the option to send people out or to be able to go meet people at different appointments or, at their house to try and figure out, hey, what can I do and help with this? Our case management services, again, huge shout out to our outreach team. They're actually doing a lot of work with just getting the vital documentation. It's usually where they're starting when they're working with folks. And that obviously builds some trust and that builds a relationship. But when you're experiencing homelessness, usually you're losing your IDs, your birth certificates, social security cards, insurance cards, all the things you need to be able to get into housing or treatment and things like that. So that's usually a lot of the places that they're starting is helping them with the vital documents. They're providing a lot of that treatment coordination, so again, not only with substance use, but also with just other case management services. So going back to that housing, how do we get you a working phone? How can I help you get your insurance on? Just basic treatment coordination. We have our harm reduction messaging that we provide, and a huge Narcan distribution. So that has been very, very helpful to be able to get and build that relationship and build that trust with folks. And then once in treatment, it is a little bit similar, but also a little bit different. Again, we're still using that motivational interviewing. I think that's a huge component that we all know about for substance use treatment is trying to meet folks where they're at and then helping them come up with their own solutions for a problem. Harm reduction, so if they are in our IOP or OP services, if there is a lapse or a use, that doesn't mean see you later. Good luck, have a good life, right? We're trying to kind of wrap around them, trying to figure out what else can we do. What other kind of community collaborations we can provide. In our IOP setting, we do a lot of psychoeducation in our group format, which is really helpful. Kind of going back to that THC use, we've noticed a trend of every time we start our group, we have them do a check-in. So, has there been any use? What skills are you using? How are you feeling today? And when we start to notice that everyone is saying, yep, I have THC use, yep, I have THC use, we pull back and have a conversation about that. Say it's interesting here that this is coming up as a pattern. Let's have a conversation about what that looks like. And so obviously we're doing that in individual sessions, but I think it's more powerful in the group sessions. So collaborating with our other community partners, so we know we can't do it all. So we are very blessed to be in the Hope. We have Hope right downstairs from us in the Wilson Street building, so we can tap them as well too for groups and peer recovery supports, which has been amazing to have. So we're increasing those meaningful activities, connecting to additional resources. If needed, we're referring to that higher level of care if appropriate, so PHP, residential. And then we have our weekly team meetings, our team huddles, where we kind of come up with some success plans or put folks on periods again, how do we help you be successful, right? So things aren't going maybe the way that you anticipated. What other services can we pull in? What other meaningful activities can we talk about? And we try and kind of wrap around them and come up with some creative solutions. And again, we're doing the Narcan distribution as well when they're in treatment. Our continued challenges, so the availability of resources when a client is ready. That continued stigma around substance use. So again, not everyone is very forthcoming with how much frequency, intensity, how much is happening for them. So that's always, something we have to kind of divulge as we go through treatment. And then substance use disorders, when someone is with that challenge of experiencing homelessness. I mean, Dimension 6 in the exam is all about recovery supports, and not that having a home is that whole dimension, but it plays a huge role in it if that's something you're trying to work on. And then the successes, again, I want to highlight, because I think we have done a lot of work in the community, especially in Manchester around substance use, so those access to MAT services have been so helpful. Meeting clients where they're at in all stages of change, so coming up with different ways to meet people where they're at.
And then breaking down barriers such as transportation, health insurance with health insurance, becoming more readily available to everybody. Now they have access to so many other additional services that help us in the long run. And then offering that array of services to meet clients. So, you know, if this outpatient service maybe isn't meeting where you're at, then let's kind of come up and be creative about what else can we come up with for you. Did I hit something?
No,
Melissa did.
I just want to make sure that the folks on the phone haven't chatted.
I
Not at all.
love having clickers, but apparently I'm bad at them. And that's just my information as well too, so if anyone has any questions. Like I said, I'm echoing a lot of what we're already kind of talking about today, which is great to hear.
Well, first of all, thank you for presenting.
Sure.
Also, so with Spice, do you feel like it's something that's coming up once they're in treatment, or are they coming to you already kind of using the Spice?
I would say already.
Already?
Mm-hmm. And unfortunately, I think the potency lately has been incredible.
Of the Spice, yeah.
Yeah. So I don't think it's necessarily gone down, I think the potency has increased.
Okay.
At least that's what I'm hearing from the shelter, especially.
And are there any cropping up of any psychiatric problems related to that? Like, I know that can cause some psychiatric problems or some psychosis. Have you seen that as well, or?
Not in necessarily the modality that I'm working in, but I imagine, yes, as we're thinking about PhD residential treatment.
Maybe other people know the answer to this, but as far as some of the Medicaid managed care organizations, I know they're trying to work on social determinants of health and transportation, and homelessness is a huge nut to crack, but are you having any, partnering with them, or once people get on Medicaid and pick their provider, like Healthy Families,
Yeah, I
or
think-
Ameritas?
I think a lot of the MCOs are offering a lot of services now, so, we use CPS all the time. Even getting prior auths is a lot easier now to provide treatment to folks, so I think having the MCOs with all of their resources have been a huge success altogether. Does that answer the question? Okay. Yeah. And I think the accessibility, so folks who weren't eligible before, maybe now are eligible now, so it's been a huge help to us.
Policy-wise, I just wondering if there's a way to move them toward looking at, you can't, without homelessness being addressed, they're most of them for profit. You're not gonna make a profit off this person, so, I don't know.
One of the problems that we have is when patients are thriving and they find a job and they do like $100 more than the minimum, they'll drop down on the insurance. So we began again, but I cannot go, I cannot pay my subscription, I cannot pay for Vivitrol, and they do that. And because even we say, don't worry about paying the visit, but they need to cover the medication. And it's a big problem because there's no understanding about that the recovery and having a full-time job, that job will not pay an insurance.
Right.
And they need to give the
The
people
same thing with
insurance.
childcare and everything, you make like $5 over and you lose a $300 subsidy for childcare,
Some patients say, okay, I'm gonna work 1 hour less, so I'm not. And so you are setting the patient straight, because the chef not having good, positive, thoughts about working more, make more money, because if I make more money, I won't have my medication.
There's no step down.
There's no.
Or health assistance, or, there's so many things that,
The state maybe can do an assistance like, okay, you are making more money, you're going to begin to pay a little percentage of this money to keep your Medicaid.
But just to kind of on top of that idea too, I think we see it while someone's in treatment as well. We've had an interesting influx in folks who, come in, meet an IOP level of care, but I can't do an IOP level of care there because I have to work in order to pay, my housing, which is incredibly high rate. So people are stepping out of their appropriate level of care in order to work, in order to afford, which, right, creates another cycle of now we have access to money and that, right, like, can create more triggers altogether. So we're seeing kind of an influx in that as well lately. It's like, great that I meet this level of care, but I can't do it. And not because I don't want to, it's because I have to work in order to, and that's where, we just have to get creative with working with our community.
In order to pay the rent, or in order to, pay medicine.
Finding another IOP that makes the hours that they can go, right, like, it's not about cheating them what's gonna
They cannot do it.
Yeah.
So just to address the MAT,
Yes.
MAT is great, but what I'm finding with, especially with the population that I'm working with, which is previously incarcerated women, is now they're starting it earlier in the DOC. They're not stepping them down, so they're still dependent on a certain level for a couple years rather than learning coping strategies for stepping down. I've had 2 or 3 women wean themselves off, actually without the permission of their provider, which I supervise, but they wanted off, and they were telling their doctor, but what about the cravings? What about the urges? And then, of course, when they're weaning off, they are going through a detox, and that 3-week period, because they're in a supported 24/7 clinical type of program, we're able to do it. But there's a huge piece of that. I get that MAT is kind of the silver bullet right now sometimes, but it goes on for a little too long. So how do we have those conversations? How do we start those conversations about, we don't want to create another methadone from the 70s.
It's very difficult because some patients are going to be dependent on following buprenorphine or Vivitrol. I have a patient 47 Vivitrol and is not able to stop. Right. But the idea is you have to combine, and every patient is different. Some of them, they want to go down fast, and I do, and I said, okay, let's do it to your pace. So whatever is your body feeling and going very slow. But there are patients that I know they never will be able to stop Suboxone. And I don't think this is a bad thing because they are thriving, they are good society, they are wealthy, and
But what about the ones that want to? Those are the ones that I'm really referring to.
Oh, those are the ones that they need to be work together with the LADAC and they go down. The big mistake I think is going down too fast.
Right. I agree.
You have to taper very slow.
I agree.
If you really taper them slow, they are able to stay. But some patients sit down, they are free, and after 6 months they come and say, I need treatment again. I relapse. So it's not that.
No, it's not a perfect science.
It's not a perfect science. It's a combination of both.
Right.
I think it's always, I tell my patient, I cannot do anything for you 100% if you don't do your therapy, your groups and everything. And what I'm giving to you is a tool for you to get treatment.
Right.
As long as we understand that. But some of them, they're not willing to stop.
Right.
And I talk with them every 6 months. So what do we do? Do we taper? No, I'm not ready yet. Okay? So, and as long as they don't use them, those are the ones that I don't find the more stable. I don't find cocaine or methamphetamine. So the new ones in the MAX program, they are the ones that can resolve. But the people that we stable for the last 4 or 5 years, the only thing that you see is buprenorphine that you're
Right,
going to swab,
right.
so.
Right, clinically, the goal of MAT is not, it's not like there's many paths to recovery, it's not like the standard is to be off it. And, you know, different people have different things that happen to their pleasure receptors, and for some people, without some level of medication, they honestly can't even feel happy or experience, you know, normal euphoria, seeing a happy thing. So, I mean, I think, you know, there's a lot of discussions about looking at it analogous to, you know, maybe someone has type 2 diabetes and is due to being overweight and being sedentary, but we would never deny them insulin, even though they could make lifestyle changes. And, you know, I think the other thing too is a lot of people feel stigmatized being on MAT, and their family feels like you just exchange one drug for another. And so it's like Dr. Sylvia said, it is a really deep conversation about where is that coming from. And we have an MAT community practice, and there's been several physicians in that have had people that had self-efficacy and really wanted to go off, and they tapered off, some without the physicians being in support of it, and then they relapsed and died because their receptors are so raw and they haven't used in so long. So it's complicated.
It is very complicated.
Yeah. And I think people, you know, I hear a lot about the stigma of you're using, or you can't come into this type of housing because you have to be off everything, you know, or. So
That's huge, that's really huge, and I have to say that the 3 that weaned themselves off were because they were getting denied on housing. So, so that's the other conversation, right?
Right.
So MAT is becoming so that's a really good thing, like MAT is becoming a big thing in the state, but nobody's looking at the unintended consequences, and that's huge, that's huge.
And just to build off of that too is great, like I have my fentanyl, my opioid use under control because of, you know, the Suboxone or buprenorphine, but what do providers do when now we have continuous access of cocaine, or now what do we do when we continue, do we keep them on that, or do we use it as a tool to say, no, you actually, I'm gonna withdraw this from you in order to make you always get a higher level care? It's just such a dance, that's really not a right answer.
Yeah, and one of the things that, when, you have any doubt about how they use Suboxone or no, and some of them, they stop using Suboxone just to use fentanyl and then go back to Suboxone. Now we have Sublocade. That is, so many patients, when they try, they don't want to because they feel that they cannot use with Sublocade in because it's there, they cannot stop. Every 25 days, you give an injection with buprenorphine, and buprenorphine is always level. But the people that really want to stop, they see this one as a good alternative, and they can, the sober houses, they have no problem with Sublocade. But they don't want it, the medication coming into the.
Is Sublocade pretty readily available now?
Yes.
Oh, yes, it is, but, it is available, insurance, really, we went at the beginning with a very difficult, time, just get the insurance to approve, but now they approve it in 48 hours is approved. So, it's a good tool, it's a good alternative.
There's also
I
financial.
could see your hand.
So I just had a question for those of us doing MEP. What is your approach for the patient that is doing well? Is they're on Suboxone, they're doing well, they don't have fentanyl or opiates in their system, but they are using cocaine regularly, and they're not interested for whatever reason in a higher level of care. I mean, for the most part, we're approaching it from a harm reduction lens, and then, okay, well, you're not using fentanyl, so that's good.
Yeah.
But then we're kind of like, well,
They
now what?
They come more often, for example,
Right.
I have a patient that is coming every 2 weeks, and it will be every week, and if every week still, every week, you will come twice a week. So finally, in a conversation, and if you really want to continue, you need to do more MIT, more LADAC, you need to do groups, or you need to go back to IOP. And finally, it takes time, but they stop. I have a patient that was moving, so 2 weeks, 1 week, then twice a week. Now, the 2 weeks I have cocaine free in the urine, so it means that in this conversation, did you reach the person that is giving to you? Is your family? So you have to, because the person who uses always at risk that the people that were selling them, they will reach again and they will see them. And this is part of the conversation that every time they come for Spokane or for Vivitrol, I have with them.
And for methamphetamine use, we have some patients that are using, is there a, like inpatient option for detoxing in the same way as?
Yeah, when we were in the, having that unit that we don't have anymore, I had some people with hallucination, and I use antipsychotics. I use Ardo until hallucination stops. So, but it's only temporary medication just to ease during the time that the effect is going away. But then, if there is anything that is at risk, it will be in the hands of the psychiatric evaluation and see if there is something else. But and they feel so depleted and tired, so there's not such a difficult thing. They want to sleep when they go out of the stimulants. They want to relax and sleep. So.
And if it's not a medical detox, then they're having to do it in essential treatment.
Right.
So, I mean, that's 99% of our women that come in, we're also having to treat for detox because they're there for our level of care essential, but can't ignore. So they're, detoxing. So we have to treat all of it. So.
I think it brings up great discussion questions that I don't know if we'll ever have a solid answer to, but.
Thank you, sir.
Thank you.
So I think,
Yes.
that we'll take our break now, and then when we get back, I'll build on Sarah's discussion about spikes, and also talk about kratom. But let's take a 10-minute break now, so we go to the bathroom.
Good.
Yeah, I know, she shouldn't be allowed, right?
She's always on vacation.
That's my problem.
She goes good place.
Yeah, Hawaii.
I know.
Awesome.
That's because her husband, goes to Japan all the time, and I think they have, like, thousands and millions of miles worth of this, that, and the other thing. But, lucky her, I wanna go to Hawaii.
I don't go anywhere. We're going to kratom.
Oh, you are?
The 19th or the 29th.
Oh, lucky you.
Scuba diving, I think.
Good for you.
Yeah, except now I hear that building, all these different things like that.
Yeah, really, what, you're not to call me.
Yeah.
Well, call me.
One of the guys was like, well,
And what could I do about it?
Right.
Say no, and bring it back.
There, and I was like, and they wanted me to check my right now. Okay, please. I will do as much as I can in the next 3 weeks to get everybody ready. But,
Oh, how fun too.
yeah.
Wow.
No. We actually got certified for cannabis. We only went to
We're gonna have a
and it was really hard. So now we're gonna go back and do a lot more vote and all that. They were I would love to. They did
Actually, that's the
Well, they did the year meeting this year, and we were gonna go, but they were like financially losing, here. Yeah, we weren't ready to do that yet. So, very cool.
Right now,
I love that when the divers, so anybody would say, when the divers were going to come on, and it was very like, busy. They didn't want to leave their place at night because they have. And I'm like, I'm not really.
right now.
We go to Belize, not to die, down at Placentia, which is, there's like a little stick out in the hills, down at the top, way down. I love Belize, we're going back in January. I love it. I just, the people are the nicest people.
Keep your numbers.
Yeah.
Oh, you mean, where are the good places to go? We're going with the divers, but they don't always go to places, like they're going to the Philippines in February, and I'm like, I'm not going to the Philippines.
No, the diving is supposed to be amazing.
Yeah.
We're kind of down farther. I think most of the people that dive go to, Amber Cave, which is up north, which is closer to the But the reef run all the way along, so we go out to this place called Ranguana Key, which is it's a privately owned island. It's the most fun. You can take a boat out, and it's way out. It's like 2 hours. Like,
That's like the blue hole.
yeah.
Like, that far.
And you want to have lunch, farther out, but it's very fun. But Belize is great. I love it. And it's relatively cheap to get to.
Yeah. That's the thing, is like, you can get there, and,
And the, well, down where we are, you can drink the water.
that's good.
Yeah, they have, desalination plants in the town, so you can actually drink the water without worrying. I don't know, like in Belize City, if you fly to Belize City, then it'll take this little,
That's an issue, right? Like, where is it happening?
I don't know, I love Belize.
I would love to go. We have this group trying to get it filled.
Oh, I wouldn't know about that.
Yeah, exactly.
So, pick Belize.
Yeah.
I don't, I've seen pictures of Blue Hole, I've never flown over it or anything.
Right.
But it's supposed to be amazing, just so cool.
I know, that's what I'm like. I've heard stories about it, and I really want to.
And all the diving people go there. Amber.
But he always responds like diplomatic, and my email is when I tell him to run off my name.
Right.
So it's like, oh, like I think there are some for you, but I see John Reagan, I can hear.
Yeah, I can't remember now, but when you get off the plane in Belize City, the airport is like a bus terminal.
Oh, yeah, well, that's how all of them.
Yeah, which is actually pretty fun, and, here we go. And then they have 2 little airlines that take people wherever you're
And not
going,
everybody's gonna be in a.
which is really like a bus terminal.
Right, that's how it is in, you get on the plane,
It's a good thing.
watching them, like, take your stuff off at the same time, on the tarmac, and you're standing out there waiting to get your stuff out. It's fun.
Yeah, but I'm a huge fan of Belize. And the place we go, we rent a villa. We rented actually in the same house for 3 years.
Yeah.
2 bedrooms, has a kitchen, bike, we ride our bike into town, go to the grocery store, buy food.
Yeah.
It's like the ultimate.
Yeah.
And the little man comes along, he's like, "Would you like a drink?" You're like, yeah, I would actually. They do make money, but
Well, why didn't go there, we have like a,
oh my goodness.
I know. make sure that right out there, and no, you can add, but yeah, you are gonna find out.
Oh, nice.
All the stimulants, right, for us. So what we do, we go out on the road diet in the morning, to go back and say, okay,
Like that where they're at, oh, out here, even if you drive our places, like.
or over here, and go back to our room, get all of our gear, and go out, just walk out, grab a tank, and go out, and the reach ran out. So, I would go back there, like, but there's nights all around, that are yellow, drive around your own,
I would like that. You gotta, everything in threes, doesn't wanna load. Here we go. Buy a place. No, I don't. I'm unemployed, I don't have any money. Good job. It's Amber,
When the budget came out, it was only available for communities with a certain level of overdose, and then we approached everybody in the national yes, we are. So, in the GNC letter,
anyway, police, I think you gotta go. Amber, so it's like one of these barrier islands. So she could fly to City, and take the whole plane out. Island known for water sports, scuba diving, and Caribbean beaches.
you're almost like forcing
The police barrier region is there. And then 124 meter deep blue hole. San Pedro, that's what it is. But police is wonderful. That's like yesterday, 2 hours calls every day. And Rhonda got in the middle of Rhonda thinking she got a math. Yeah, and she, it wasn't. And Rhonda called me, oh, I just talked to her and I just wanted to see her. All right. I heard on Monday that one of my brothers. And I said, oh, no, did she have a little boy who was helping her go and did mine? And there was a man over the weekend. That's so great. I'm sure she did. Oh, I didn't even know that came at 3 million. Oh, yeah. Yeah, and then we had the discussion about, you know, you have to go to the dealer to get the grandma and grandpa. That you should be staying away from. So, no, they didn't make me pay for it, even though.
Oh, God, yeah.
So,
yeah, okay, that's what I want.
I'll call her to me back. You know, maybe when I
We're exactly on that. Yeah. That's it, yeah, we'll pay for it.
So what are we going to do? So I have to get back to the
Video.
Hey, it's in mine, but my phone is like, get it.
Oh my God, thank you.
I have to keep things close to the best.
I'm so excited to go with Grand Canyon. That was so fun. I'm ready for it now. I love the warm weather. I can do this. Yeah. Perfectly happy. He can't. So he's not going back to about 2 years, and last year he pitched the whole time. He was like, I'm going and you're not. Yeah. And I was like, what are you going to do? I said, nothing. And I'm like, where are you going to go? For a week. Oh, I can't lie, yeah. But it's so fun and so beautiful and, you guys buy.
So our doctors heavily riders on Saturday.
Good idea.
But I've heard you that don't like to make it.
Yes, oh, that's great, wow.
They make me do it.
All right, so I'm gonna bring us back to start talking about, spice and kratom. Sarah had mentioned, especially in the Manchester area, we're gonna talk about some of the very current events, related to this spice. You wanted emerging, we're gonna do emerging. So we're gonna start with spice, then we'll move into kratom, and then we'll have Paul, like I said, especially since these two substances, are unfortunately kind of like, yeah, I'm not sure what you do there. Good luck. We're gonna work through it together. So, spice, I'm gonna do kind of similar things to what Paul did for marijuana and stimulants. So spice is a form of a synthetic cannabinoid. I didn't do what Paul did and sit in my car and know how to pronounce that, but I feel relatively confident. I was going to say, though, we're such nerds. I did it for kratom. I Googled how to pronounce kratom, and pretty much it's either kratom or kratom, so I'm going to go kratom because it rolls off my tongue easier. So spice is a form of synthetic cannabinoid. There's K2 that also, when I was in high school, I remember kind of K2 came out. And this picture I just liked because to me it was like the best picture of that's a more natural, traditional marijuana over there, and then you can see a little bit of the difference of how spice looks. But sometimes they do look remarkably similar. So synthetic cannabinoids are human-made, mind-altering chemicals that are either sprayed or dried, shredded plant material. We'll talk about how they're used. But something that's interesting about them is that they're oftentimes referred to as fake weed or synthetic marijuana, which makes people think that they're just going to be exactly like marijuana, which is not exactly the case. Some people actually think that since they're legal, they're sometimes referred to as fake weed, that it's a safer alternative because it's more widely available and all that. So unfortunately, they are not safer than traditional marijuana, and they may affect the brain much more powerfully than traditional marijuana, and their actual effects are pretty unpredictable depending on a person, which we'll talk a little bit about, especially with what's been happening in Manchester and what they've been trying to work through there. So synthetic cannabinoids are part of a class that are being referred to as new psychoactive substances, or NPSs. These are unregulated, mind-altering substances that might be more readily available on the internet or in smoke shops. Most of what I'm going to talk about is pretty widely available in your local smoke shops. I was just in Maine over the weekend, going on a hike, and when I was driving down the road, I passed a few smoke shops that had light up neon signs for everything that I was going to talk about today. And I thought, oh, you could come on down and you know all about it. So spice is very popularly used among young people because of its easy access and the belief that it is in some form natural and it's less scary and all those kind of misperceptions. And spice is also, and all synthetic cannabinoids are pretty difficult to detect on a standard drug test. So like Paul was saying, in a lot of programs might not be seeing it, but it doesn't mean it's not there. So spice is used very similar to marijuana. So smoked with bowls, pipes, joints, also vapes. These were referred to on the internet as K2 starter kits. So a nice little handy kit to get you started And then Eaton and Brut ST. The Brut ST is a little bit different. I think you don't see it as much as traditional marijuana, but maybe I'm wrong. But people talk a lot with synthetics about the kind of happy foil packaging and how appealing they are to younger people, and then again with the easy access, and then, you know, a good old traditional brownie there. So very similar to how marijuana is used, but like I said, not similar effects. So there are some similar effects to marijuana. However, it's really hit or miss on if the other things are going to start to happen. So you have your elevated mood, relaxation, altered perception, but then those symptoms of psychosis. So that seems to kind of be the theme of today, I'm realizing. You know, Paul was talking about it with the higher doses of marijuana, then it came up again in the stimulants, and now here it is again in spice. So these do act on the same brain receptors as THC, and so there have been few scientific studies on the effect of synthetic cannabinoids on the human brain, but they do know that they bind more strongly to the cell receptors than a traditional THC, and so therefore they produce much stronger effects. So some of the psychotic and adverse effects, this is specifically labeled that because the psychotic effects are pretty common. Extreme anxiety, confusion, paranoia, hallucinations, rapid heart rate, vomiting, violent behavior, suicidal thoughts, and then continued use, kidney damage. These are disorders may develop. So some of the kind of altered perceptions is not really being aware of where you are or what's around you. Again, delusional or disordered thinking, extreme and unreasonable distrust of others comes in with the paranoia. And then obviously now know what a hallucination is. So some of the things that they're seeing in the emergency rooms is kind of hanging out down here in this category when the first responders don't know what to do with a person. And then similarly to, as Paul was explaining with the stimulants, it's a very different setting in an emergency room, right, than a more traditional opioid overdose. So because of these types of symptoms, spice can be addictive, and those who regularly use spice can also feel effects of withdrawal, obviously. So those types of symptoms can include headaches, anxiety, depression, and irritability. And so they're finding that use of these types of drugs are also contributing to more and more deaths, again, because of mixing, which is another theme that we've been talking about. So this is what I mean when I say very emerging. So last weekend, if you didn't see, poor Sarah and the FIT team had over almost 20 people at the, mostly are concentrated around the shelter, but not just there, falling ill from what they believe was fighters. The poor first responder team in Manchester was certainly feeling completely overwhelmed. But they reported symptoms of overdose, including manic behavior, erratic movements, and inability to focus. But something that I thought was interesting, as the first responders shared, was that sometimes it's really hard to know because it's presenting so differently. Sometimes someone might appear that they're sleeping, and they're kind of in a heavy spice time, and then other times it's really going manic and erratic. And they're finding that that often might be related to what it is laced with. So maybe it's an opioid or an hallucinogen, more liquid THC, or other illicit substances.
And unfortunately, sorry,
No,
but
please.
unfortunately, I think a lot of it is leading to the seizures. And so that's, again, why first responders have been called so much, because again, like having staff deal with a seizure, it turns into a medical emergency.
Yeah.
And so I think that's what's happening.
Yeah, terrible. And so they're kind of, in the articles that I was reading, they were talking about how this has kind of been like a wax and wane thing. It came up a lot a couple summers ago, and then it was a little more quiet, and now it's coming back again. But, you know, it's difficult to find, because it is so similar to marijuana, and the symptoms and the signs are so different. So they're really struggling with it. But they said that, again, similar to people had mentioned about meth, like getting cheaper and cheaper, right? So a single bag for $5 to $10, and then several people can use that together. And that obviously leads to instances like this. So then we kind of get to the sad news, is that behavioral therapies and medications both have not been specifically tested for treatment of addiction to these products. where we kind of really get into emerging. You know, the meth use and marijuana use has kind of been around back in the day. We have some idea of what might work. But these substances specifically, we don't yet have the research on it. So Paul put in, his standard line treatment strategy should be based on the problems identified in the assessment as well as the person's strengths. And then maybe a little similar to the marijuana treatment strategy that we mentioned, just because people seem to be using it, thinking that it's gonna be similar to marijuana, so some of the motivations, may be pretty similar there. So I'm going a little fast just so that we do have time to talk, but are there any questions about spice or cannabinoids before I move to kratom?
Is it true that the compounds that are in spice are frequently changed? Like,
Yeah.
literally, like, that's why the DEA can't keep track of it.
Yeah, so they were saying that, as becoming more and more of a problem, they are trying to regulate it by making some of the, components of it illegal or harder to get, but then they're just changing the components.
Right.
Yeah.
Like bathrobe.
I had heard that what they were doing instead is trying to regulate the effect rather than the chemical compound and having more success that way through enforcement. In other words, it became illegal to make something that would produce this effect. And so then it didn't matter what the chemical composition was. Is there any sort of baseline understanding of what chemical or family of chemicals is the active ingredient?
Let me see if I have it back here. If not, then I'll pull it from one of our references and send it out to the Google. So let me just see if I have it easily here. There were some long words that I didn't read. I don't think so. So I'll look and get that for you, because I do think I read it, but I probably didn't write it down because it's a long word. Is it on the fly? Okay, so now we'll talk about kratom, which is, like I mentioned, Melissa has the prevention community of practice has come up there, and it seems to be the one that people know the least about. So we wanted to do more of that background. We hear in the prevention community of practice that over on the seacoast, people are seeing it a lot, and then when I was over in Maine and seeing light up signs for it just over on the other side of the seacoast, you start to understand why they're maybe seeing it more over there. But this is coming up more and more in New Hampshire, especially in the recovery community, which I'll talk a little bit more about, which is interesting. So kratom is a leaf from Southeast Asia. It's a tropical tree with leaves that have psychotropic effects. So I think, back in the day, it was typically just kind of chewing on leaves to get the effect, but now things have obviously progressed. So not currently illegal, very commonly sold online, but now also moving into smoke shops as it's obviously generating profit. So it can be sold as green powder, extract, or gum. Something that I thought was interesting is that they said that a very common way in which it's sold is like a little bag of powder that says on it, not for human consumption. And I said to someone at work, I was like, so naturally, as humans, we decided to consume it and see what would happen. But very commonly, so this is the powder, these are capsules, and these are pills. I think probably your most common, sell in smoke shops right now is going to be the capsules and maybe some of the powders. So the FDA has listed it as a drug of concern, but very little evidence behind this on what it does, especially because of this component, where it is both a stimulant and a sedative, depending on who you are and how much you're using. But they find most traditionally at low doses it acts more like a stimulant, and at higher doses can act more like a sedative or an opioid. So again, like I said, how it's used, the pills, the capsules, it kind of gets hard, right? This all starts to look like kief, then it starts to look like synthetic marijuana, and so how do you know this? The extract, the chew, brewed into tea again, so again, similar to the synthetic, smoked or just eaten, again, chewed, or baked into things. So the effects of kratom, which I thought was just fascinating, that it has the ability to do both. So in smaller doses, the stimulant effects include energy, sociability, alertness, and then the larger doses with the opioid effects include sedation, pleasure, and decreased pain. But then some of the things that it can lead to, again, the theme of the day, nausea, itching, sweating, dry mouth, constipation, increased urination, loss of appetite, seizures, hallucinations, and psychosis. Now I feel like I'm one of the, side effects may include
Sometimes, one of the ways to understand how a substance can have both effects is that some of the brain receptors are receptors for those chemicals that we generate when we're experiencing fatigue, things like adenosine. So if you've got a chemical that can block those receptors without triggering the feeling of fatigue, like caffeine, for example, that's how caffeine actually works. Then you can feel energized and alert. Now, if that same chemical also can occupy things like opioid receptors, now you feel drowsy and sedated. So that's how you can have both effects at the same time.
So they are starting to find, this is kind of a, what I'm looking for, like, okay, I'm not gonna find it, but I'll get there. So they recently published a report the CDC did with some data from 2016 and 2017 that stated that more than 90 deaths in the U.S. have been caused by kratom. Oh, controversial is the word I was looking for. Because a lot of people are saying like, oh, that's not, you're not accurately kind of portraying that as saying that the deaths were caused by kratom. Because nearly every single one of them was kratom mixed with something else. So again, the mixture is happening. So fentanyl and analogs being the most common substance detected mixed with kratom, which when I start to talk about kratom as treatment that some people are starting to find, that's kind of like a sick job. When you're trying to use kratom to maybe not use fentanyl, and then you may accidentally get kratom that has fentanyl in it. So many deaths appear to have resulted from adulterated products or taking kratom with other potent substances. So it's not just fentanyl, can also include benzos, alcohol, gabapentin, over-the-counter, cough syrup. So that then also might be people not understanding, I don't think we fully understand yet how those things are going to interact together. So if someone, unknowingly takes maybe an over-the-counter med that they have with a kratom capsule, and does not have it. So because of its opioid-like effects, it can lead to physical withdrawal symptoms, including muscle aches, insomnia, irritability, hostility, aggression, emotional changes, a runny nose, and jerky movement. So this is what I wanted to talk about, which is where it's really kind of in the discussion in the recovery community in New Hampshire is kratom as treatment. So in recent years, some people have started to use kratom as a herbal alternative to medical treatment in attempts to control withdrawal symptoms and cravings caused by addiction to opioids or to other addictive substances such as alcohol. There is not scientific evidence that it is effective or safe for this purpose, but it's certainly word of mouth and anecdotally people are really saying this. So in New Hampshire, there was a bill maybe last year or the year before, 2016, right there, that was going to ban all kratom sales in New Hampshire. But after kind of a lot, they said over and over again, individuals giving heartfelt testimonies about the different ways that they could use kratom. They used it for menstrual pain, they used it to get off opioids, they used it for joint pain, anxiety. So then that caused the legislature to really start to question how dangerous is it, we don't know enough, a lot of people are telling us it's helping them, so they amended the legislation to only apply to those, to minors, to 18 and below. So in New Hampshire, it is still considered legal to purchase for 18+, except not if you live in Franklin, because just this month, Franklin, the prevention community there, made a big push and they banned the sale of kratom in Franklin. So we might start to see more of that, small municipalities popping up and decided that it's not in their community. And then the same slide as we found on Spike, which is, very new, not finding specifically tested to the treatment of kratom addiction, and also paired with, like I just said, a real lack of evidence around kratom as treatment. So this one is interesting because we're looking at it from both perspectives on how harmful is it, but then also how helpful is it. So any questions there?
I'm just wondering, how often are you all testing for this in send-outs for your urine drug screens? Because I don't think we routinely.
Does anyone?
We do.
You do?
Yeah, at the Choices program, we have drug courts so we test for it, but we also test for it if we see, we'll send out a confirmation. We have an on-site lab, but we'll send out for confirmation because if we've noticed a difference in someone's demeanor, any heightened conversation that we were having about a person, we'll send it out.
Are you seeing that it's
Oh,
coming
yeah.
back positive?
Definitely.
And it won't, there's no quick cut.
No, there's not.
Not yet, anyway.
No.
Are they FDA approved, like the fentanyl?
Well, and I don't see how they can do a quick fix because it's not regulated.
Not regulated.
You can put toilet bowl cleaner in there, you can put like
Yeah.
whatever you want in there, the head shop, you can put whatever, so like, there's no way to make it.
Yeah.
First, like,
Because some
freedom, maybe.
are gonna show on a pendant and some aren't.
Yeah.
But patients don't talk about using spice, but they talk about using crack.
Yes.
And some of them say, I'm gonna go out of Boston because I do that, and they disappear. Then they come and they realize that they cannot stop, and they go back to Boston. Or I have a patient that because of kratom, he was so afraid to go back to be withdrawal, so now he's in Boston because the detoxing are very close to
So you're finding people leaving MAT to try kratom.
kratom and be a natural life. Yeah.
Yeah.
So will they have, if someone's using kratom and they start Suboxone or Vivitrol too soon, will they experience precipitated withdrawal?
The doctor answer?
That's an awesome question.
We can look that up and also if you have any.
That's a great question.
Yeah, we try to, if somebody comes and is taking kratom, we say, you have to wait at least 24 hours, and then if you for Suboxone, and I really don't feel comfortable doing Vivitrol immediately because I don't know what's going to happen. Really, we don't know so much, so it's better if they can wait without using, and they have a
If we know.
support, we wait and we do Vivitrol. Otherwise, most of them they go on spot. But with a small, it's like any patient, you have to do very low doses and wait enough time to begin with.
We'll look and see if we can find anything, and then if you also aren't or want to be a member of the MAT Google, that would be a good question to throw out to them.
I just heard yesterday that they're selling liquid kratom, like right next to the energy shops at some Irving gas stations on the Seco.
Wow.
Yeah.
Fantastic. Because we don't have enough worry about what's going into your cigarettes.
The energy shop, the energy drinks is a big problem also because they are carrying around 3 to 4 energy drinks a day, people who are in treatment, and it's not good. It's really not good. So hypertension, arrhythmias, and they are so irritable. So, yesterday I have a conversation about the energy drinks. No, I'm not going to take any more. And he got Vivitrol, and when he go out, he opened up the food.
He's not a monster, what do you mean? Harm reduction for energy.
Yeah, but it's very concerning about those energy drinks. So everywhere.
So we want to start to talk about, and really hear from you, which you have already done, and that's, why I wasn't so worried about time, because, we have so much time built in for discussion, so whenever it kind of happened, I wasn't too worried about. But we do want to start to figure out, hear from each other, since you all are here and you don't get a ton of opportunities to talk to each other. It sounds like, we built some consensus in the room that people are seeing a lot of the same things around stimulant use and marijuana use. And then, maybe starting to test for these things and finding them as well. So, what are you doing with those patients? And I'll kind of hand it over to Paul because he has, knows the right questions to ask. But, now we want to talk about, even if it's like, well, with one patient, I found that this works, helpful to share with each other because it could work for someone else.
Yeah, I would echo kind of what Addie said. We've spoken a lot about some of the obstacles that you're experiencing, but what are some things that are working? Or what are some, some approaches that you guys find are working well for you?
Kind of comes back to, when you don't have an evidence-based practice, and you kind of throw up your hands and fall back on what you know works in general, that's what I'm finding is the truth, because there's a way of thinking about all of these compulsive behaviors and substance misuses as someone's attempt to deal with life isn't good enough without it, at least at first. That's their thought, kind of. Let me try this, maybe that will make my life better. So a lot of the interventions that we use to have them look at things differently so that they look better works. It doesn't have to address which of the substances they're using when you come to the basic, well, how do we make life good enough? And have them get an idea of that. Then all of the attention that they used to put on scoring and using and getting away with it now can be put on making some kind of accomplishment. And that works.
So treating the person as a whole.
Right.
Looking at the individual pathology of different substances, looking at the individual as a whole and how to change their thinking.
Yeah, the use of a substance or a behavior to solve the problems isn't, those are symptoms.
Yeah. Well, I mean, if those of you who are in 12-step, programs and who come from a 12-step modality, if you read some of the, the 12-step literature, it's bottles are about a symptom. Talks about that, and that's, it's old-fashioned CBT. That's all it is. Thank you. Others?
I'm sorry that Sarah left, because I wanted to ask a little bit more. Regina and Sarah started talking about treating some of those social determinants, and I know that is such a huge barrier. And Sarah was sharing that they were having some success with the Medicaid MCOs. So I'm wondering if anyone else can kind of talk a little bit more about what those successes would look like, or Regina, if you know kind of how that's been able to help, because that was kind of the first time that I had heard someone be like, yeah, the MCOs have been super helpful in treating the social determinants. So I was hoping that she could stay and share some of her tricks, but if you know, or we can follow up with her.
Well, some of the benefits.
I just wanted, to clarify, are people aware, they're familiar with social determinants of health?
No.
Okay. So maybe we could, just touch on it a little bit.
Thanks.
Just to give just so everyone's clear on it.
Yeah, so essentially, it looks at, income, housing, employment, education, all these things that factor into what people's health is, that socially, all those determinants. So, and that I had worked in public health and had worked on other health issues, and the CDC was really moving toward trying to work on larger systemic changes to move the needle further for more and more people versus individual. So the idea is immunizations versus individual counseling. You get a lot more bang for your buck. But I do know that the different MCOs have different plans. Some of them do, one of the benefits is to provide a cell phone. They do have Medicaid transportation. It's not pretty. You have to call and have advance notice and things like that. Some of them have, bicycle helmets for kids. So when you're on Medicaid and the new managed care organizations come on board, they send people information for you to choose one. Some of the things they have, which I think is moving the needle in the right direction, is like infant car seats, things that some of us just take for granted. And then depending on where you are in the lifespan, that may not be what you need, and they may have other things. So, New Hampshire Healthy Families has been around for a couple of years. There's a new one, Ameritas something. I heard an ad for it this morning on the radio. Yeah.
AmeriHealth.
Yeah, and so, I think they're helping a little bit. I mean, for me, I think the crux of all this is housing. And, I know that the state of New York and New York City was trying to get a Medicaid waiver from the feds to basically say, the best way for us to treat someone with uncontrolled diabetes is to house them. And the federal government, and this was during the Obama administration, was really afraid of kind of like going down that road. But I think just having that discussion around somebody managing diabetes when they're homeless is pretty ridiculous, you know? I mean, I can also get some information from the department, from DHHS in terms of the different benefits, because I think whatever we have in our toolbox, you know, we should use. And I can follow up with Sarah too, unless you want to.
One of our future meetings, we were kind of waiting for the all clear from Jamie Powers, on how those contracts were kind of shaking out. I think the last time we talked to her, they were starting to, so we're hoping that once they do, we can have some more discussion about the new MCOs, and what that looks like, because there is still, like Regina was saying, the Emeritus, is a whole new player, and it's probably gonna be impacting most of your organizations.
It's also doing dental, because I just recently got enrolled, and nobody's done dental.
Right.
And that's
That's
the hugest
huge.
piece, you know, opioid users.
God, that's huge.
And that's, exactly.
Yeah, it's great. And phones.
And that all kind of ties back to what we were saying in the back here, is that kind of wellness approach of looking at the social determinants of health, the whole person as a being, where if my social determinants of health are taken care of, if I'm housed, if I'm, taking care of my dental care, my emotional care, if I'm employed, if I have all these things, I'm feeling better, what my self-efficacy is up, I'm less likely to, be looking outside of myself for something to feel better. So looking at everything as a whole.
Many of my clients use the transportation piece.
They do.
What are the other pieces that people have found are helpful? I mean, I heard just now about the bicycle helmets, but what else is available? Can anybody tell me?
So transportation sometimes is good, sometimes it's not, because I found that sometimes one car is transporting more than one patient, and unfortunately, sometimes it's not the right mix. Even I had patients that they're telling me that other patient that is in the transportation is using during the transportation, and nobody's able to say, okay, you have to go down. So it's a big conflict. I think they have to say, okay, you have to transport only one person at a time or one family. This is what I get from the patient. But they have the other thing that is, if they have their own car, they give the money to pay the transportation, and this is very, very good benefit for them, because actually they get more money than they really spend going back and forth. So most of the people that can do, they do that. And the other thing is dental is very important, because the patients, when they have the dental for the first day, they feel that they are another person. They feel that they have makeup. If they're women, they get fresh. They say, oh, I took my sweatshirt. I can really put something different because I can smile. So this is part of the important treatment that we don't have in every place.
Dental care is huge, because we think about how much we make judgments about people based on their mouth, and then how much we don't give them tools to care for their mouth.
And I think a lot of treatment providers, I know, I've been around in this field long enough to have some bad habits. Sometimes, when a patient's like, I really want to get my, I can think back to when I first came, it's like, well, you don't need, you need to focus on going to meetings and getting well. That patient needs to, that's what's important to them. We need to really look at that. Sometimes we come at it from that one angle, so we want to make sure we're looking at the patient as a whole and how to help them. So what else is working for them?
I just want to make a comment about that, because we do a comprehensive program that moves into transition, which takes over the ASAM Dimension 6. And I know that ASAM is working on kind of that after the 28-day, kind of 90-day rolling into transition.
Well, so they don't work in any kind of fixed length of stay.
No, I know, but are they working on the dimensions for recovery?
So they're actually in the next edition of ASAM, what you will probably see is, some parameters around recovery housing, which is kind of like transitional.
Right,
kind of-
yeah, so
They are gonna be, I'm pretty confident from the people I've talked to, that they will be addressing that in further iterations of the criteria.
So that ASAM Dimension 6 is going to carry forward, they're going to go deeper into that ASAM Dimension 6?
No, I think it's gonna be, no, it's, the dimensions are gonna stay the same most likely, I mean,
Really?
just from what but what is going to be looked at is at almost like the level of care.
Right.
They're going to define and look at, appropriate, elements for an individual to meet criteria for like residential housing or
Right.
recovery housing or things like that. They're gonna define it kind of as a level of care. The dimensions will most likely stay the same, but, someone's dimension 6, they are entered a state of recovery,
Right.
but they still have housing issues, recovering housing would maybe be appropriate for this.
Right, we're still using, as in transition, we're still using the dimension, the 6th dimension, so we're still following it through on their treatment?
Yeah, and what that will allow it to do is once you're kind of like, all right, this person has everything buckled up except for dimension 6, they have housing issues.
Right.
And they, with their financial situation, any housing they could afford is in a high crime, high drug use.
Right, exactly.
Area, recovery housing, this person will meet that criteria. That's what I think you're gonna see in the further iterations of the criteria,
And
but
when do you think that?
it's gonna be a little while.
Yeah.
I don't know, I can find out a little more information. That's a tough one, because they don't
Yeah.
know.
Yeah, but one thing is that you can write this one in your dimension, and the other thing is you can make it possible.
You get, what was the first part, I'm sorry?
Well, if you can put this one in your dimension as, we need to do that,
Yeah.
but the other thing is to make it possible.
Right.
You need the funding
You need the
to do
resources,
that.
yeah,
And if
absolutely.
you don't have the resources,
Right, yeah.
it looks very
They might be
nice.
appropriate, but
Right.
you can't send them anywhere.
Yeah.
So I'm the coordinator for our perinatal SUD program at Amazigag Health, and our work is about addressing social determinants of health, and I feel like I'm beating a dead horse talking about housing, but there are things that we can do for all of a lot of the other areas of social determinants of health that without the housing, everything just falls apart. It's a huge.
And that seems to be like the lowest priority.
It's a huge stumbling block. It's really hard. And I was just talking to Sarah before she left. I would say in the last month, I've been working with at least 3 of our patients around housing, and there's nothing there. And to think that at the shelter, they have this new requirement where they're gonna have a cap of like 130 people, and usually they serve like 160 to 200 people. It's really difficult.
I don't want to put Christine on the spot, but, you could talk a little bit about who you are. You're a kind of a newer face to this group. Could you talk a little bit more about who you are and your expertise?
I'm Christine Paquette. I own a recovery house, but I'm also the chair of the New Hampshire Coalition of Recovery Residences. And we're hugely advocating across the whole state, trying to get more housing. It has always been a problem. I've been doing this for 7 years. There's never been enough, and never enough affordable housing either. That's a big one. So there are a lot of recovery homes per se in New Hampshire. There's a lot of requirements to them too. As somebody's mentioned before too, MAT has been a big barrier for people. That's one thing that we're actually pushing through NHCORE. We follow the NAR standards, which is the National Standards for Recovery Housing, and they have formulated a whole workbook on, appropriate, ways of taking care of a resident. There's like a whole standard guide on how to actually have an MAT client in your home to try to break those barriers, because it's really difficult. And as I mentioned earlier, I have my home itself is a 12-step home, but we do accept MAP, all forms of MAP. But it's been another stigma for people to beat was, I just had a young man who celebrated a year sober. Well, in my 12-step house, they're all like, and I'm like, no, you know what, this is he may be on this for the rest of his life, but he is not using any other illicit substances, but it's still a huge stigma, no matter what you say, but the 12-step program has kept him in the house, and, he's done all that work as well, so it's really been an amazing, way to kind of show people that this is possible, and I've really been pushing all of my 12-step partners to say do the same thing, so it's a little scary for some. I'm a nurse, too, by trade, so it kind of helps. I don't have that fear of medication like other, people do, and, so I had that ability to know what a med sheet is and a lockbox and, stuff. But people just don't know. A lot of people that go in treatment are in recovery themselves, and, so there's a lot of fear around having, substances that are not legal or, not controlled substances in a home where they've never been allowed before. So there is some practice, but there is some money coming for different types of housing. That's definitely not going to be anywhere near what we need, but this is the first time that any housing has been approved for, so, hopefully it will keep coming, especially if we all keep saying, this is our biggest problem now. We've got all these funds, but, nothing has covered housing. The ideal situation would be insurance companies. that would be ideal, because then it wouldn't be a burden on the state and whatever, but I don't know if that'll ever come. Did you have a question for me? Or?
Well, I just had a point that might be encouraging to you. In my local area where I work, there is a relatively new sober house. They're probably a member of your organization, and they have a prescriber of things like Suboxone and Subutex and all kinds of psych meds, who actually comes to their house and does his work there, primarily for their residents. I mean, he does have other people from the community that come to that house.
Is that in Keene?
Yeah.
Yeah. Exactly that house. Yes, that's a great house, actually.
Through NH4, are people able to find the house, like, so Sarah's saying that some people are trying to get off MAT, they can't find a house. Did you guys help find houses that are more MAT friendly for people that are trying to?
So right now, on our website right now at nhcore.com, the certified houses are listed up there, and it does say whether they accept MAT, but because we just started certifying homes July 1st, there's only 14 homes that are certified currently. There's about 15 or so that are in the process of being certified, but there is still very limited numbers. And it also depends. Some houses will take Vivitrol, but they won't take Suboxone. And I don't know, actually, off the top of my head, any houses that will take Vivitrol. I'm sure there are, but I have not, I haven't come into contact with anybody that will, so.
And that's not a requirement of the certification, if they have to accept that.
Yeah, the only thing that NH4 will not certify is a harm reduction.
So like a damp house?
It has to be an alcohol and drug-free environment.
And they don't have that, people with.
Damp house essentially it's like a sober house, but you don't have to be sober. It's a place where someone can it's a shelter, it's not a draw shelter. It's not a shelter where you're kicked out if you're under the influence or test positive or anything like that.
Which is part of.
Some states have that model, they have sober and dry.
Yeah, we had a meeting actually, last week where we talked about this too, is the pre-treatment, what are we gonna do pre-treatment with, the respite bed and such, but that was a big problem, is because there will be active use.
Right.
Potentially.
Right. What do you do?
Yeah. Right.
Talk about social determinants of health going right down.
Yeah.
So where is that money coming from, and who would we,
BETA is, so some recovery housing money came in through the SOR fund. coalition, was actually granted funds from the Governor's Commission. So we have some scholarship dollars, so we have like $100,000 in scholarship dollars, that will be going out for recovery housing, though not for pre-treatment dollars, unfortunately. And that's, I mean, unfortunately, the contracts take a long time. So we still haven't even, we're not even anywhere near able to do that yet, but it's in the works. And then each doorway has gotten funds too. So there's a lot of funding that is sort of scattered that's not put into work yet. So that it's kind of there, and, you know, they're really looking for, you know, ideas and thoughts, and like, what do we really do with this money? Because there's money.
So the ideas and thoughts would go to those groups.
Hopefully.
Can you add in kids and family groups instead of just one person that has a whole other dimension?
Families and children are like one of the top.
Yeah.
So that's definitely above, you know, that's probably one of the number one, because it's a very big need, and it's difficult because that's such a huge process, is to take a family, you know, and then try to house them. There's so many issues there, so that's a big one.
I do know that the doorways to have a certain amount of flex funds per client, but again, that was probably just to pull people up in a hotel for a couple days, although, you know, if it gets somebody out of a dangerous situation, it's better than nothing. I did just quickly look on my phone, and I didn't see really anything pertaining to housing around the two MCOs. AmeriHealth says they'll do mission GED, they'll fully pay for someone to get a GED, job readiness, guidance to job training, ability to purchase nutritious foods, prenatal care, and then working to locate transient members to engage them in health care. And then WellSense has medical transportation. They also have like a friends and family reimbursement where a family member can get reimbursed for gas and transportation. Helmets, like I said before, car seats, booster seats, diapers. And then, this made me laugh a little bit, but like access to Weight Watchers, like you can do that, like, you know, I mean, talk about like the Maslow's hierarchy, you know. Yeah, I'm sleeping in my car, I think I'll go to Weight Watchers, but at any rate,
So we are kind of at time, so I just wanted to say that, in your slides and all year, this is a convention, this is a typo on it, this is December 6th, we meet on Fridays, so it's just the next day. I'll send that out through the Google group, just so you know, that will be our last meeting of 2020, and then Melissa and I were just working on making, less than 2019, we were just working on making the schedule for 2020, keeping with our quarterly, So, please return your evaluation, please return your fancy new name tag that Melissa had a great idea and facilitated the purchase of. We got these because we felt like when we do break up